Natasha, and Simon and Prashant will be there, and Karina will also join if she can. She's got a clinic on the day, but she's trying to rearrange it at the moment. That's my fault for not being organized enough to tell her in advance. And then on the 27th of March, we've got a really exciting program all about cesarean scar pregnancy, moving from ultrasound to management. We've got fantastic experts telling us all about CSP, including Davor talking about the London experience, Ilan talking about the New York experience with balloon treatment, Judith, who is really the leading expert in the niche of the uterus after cesarean section, Amar, who you will know from his great work on placenta accreta, Laura and Andrea, who running an international registry on CSP, and Baski will be co-chairing with me. So thank you, Baski, for offering that fantastic program. All the details on the website. So I'm not going to take any more time, but introduce Gianluigi, Gianluigi's well, everyone knows Gianluigi. He's a fantastic teacher, and I'm so glad that he's also a good friend and has agreed to talk to us today about second trimester ultrasound for the detection of cleft lip and palate. Gianluigi is a professor at the University of Bologna and has been in the game of prenatal diagnosis really from the very outset. So Gianluigi, thank you so much for joining today, and I'm really looking forward to hearing about second trimester diagnosis. Thank you.
Thank you very much. And I will try to share my screen. Are you seeing it?
Yes.
Okay, I will try to move one slide just because I've seen that sometimes it doesn't work, so you can tell me.
Yeah, it's moving.
Have you seen the slide moving?
Perfect.
Perfect, okay. Well, this is going to be a talk about the prenatal diagnosis of fascial clefts, and we decided also to add a few things about fetal micrognathia. Let's start with fascial clefts. As you all know, this is one of the most common congenital malformation. 13% of all malformation are clefts of the face with on average, an incidence that is a little bit over 1 in 1,000, 1 in 600 to 700 live birth. And of course, this is an anomaly that can be repaired, and we will discuss that later on. But one of the most important thing about prenatal diagnosis is that it is very frequently found in association with other malformation. There is a genetic etiology that is in the range of 20 to 40%. It is part of a wide range of many different syndromes. So it is important to detect fascial cleft because sometimes this is the most prominent sonographic finding of a more complex disease with a poor prognosis. But it is also important for another reason, because understandably, it is very difficult for the parents to adapt to the birth of an affected child. This represents an emotional shock at the time that the baby is born, with a much increased rate of difficulties in bonding, a much increased rate of depression on both parents, maladaptation. But it would seem, and there are good data coming from France recently, that prenatal diagnosis is beneficial in that it allows the parents to adapt to the appearance of the infants. And so that improves bonding very much. So it's very important to diagnose this condition. The postnatal management of isolated fascial clefts is not different, of course, if you diagnose them after birth, but the reaction of the parents and the adaptation to the promise of the child is much improved. As you can see, practically any part of the face can be affected by clefts. A wide range of different possibilities in any part of the face. But in reality, the vast majority, 95% of facial clefts will enter into the embryological category. That is failure or fusion of the primary embryological prominence that forms the face. So we have fundamentally two different types of diseases, cleft lip and palate, which may be a defect in the lip, or it may be a defect of the lip extending into the palate. And as you can see, the palate is going to be poorly arranged, disrupted. And this is one disease. This disease tends to occur in families. And depending on the penetrance of the condition, you may have either the cleft lip alone, or you may have the cleft lip and palate. Cleft palate is a much different condition. It does not recur. It does not have anything to do from the genetic point of view with cleft lip and palate. And of course, as you can imagine, is a real problem from the point of view of prenatal diagnosis. But we will briefly discuss that later on. Well, what do we do to assess the face? It has been about 10 years, maybe 15 years, that the national guidelines about what you should look at when you perform a second trimester examination also include views of the face and of the lips in particular. And for the purpose of diagnosing cleft of the face, there are fundamentally two scanning planes that are important. Number one is an axial scanning plane that is cutting across the anterior lip, the teeth buds, and the palate. And the other important scanning plane is a coronal view that is tangential to the face, and as you can see, can demonstrate the tip of the nose with the two nostrils, and the solid tissue of the lip that is separating the nostrils from the opening of the mouth. And I think that these two scanning planes can be used alternatively. It is going to depend upon the way that the fetus is presenting, the accessibility of the fetal face, but at least one of the two should always be obtained in every second trimester examination. There is not the same consensus with regard to the profile. Many guidelines suggest that you should obtain not only a view of the lips and the palate, but also a view of the profile. ISO guidelines say that you must include that. Italian guidelines say that this is not necessary. I think that is up to you, of course, and obtaining a profile is slightly more difficult than obtaining the two views that we discussed before. And of course, in some cases, it may be impossible. So you may have to reschedule the patient. Is it really necessary? Well, honestly, I have difficulties in performing a second trimester examination without seeing the fetal profile. I do not think it is complete. I do not think that I've seen the face of the fetus unless I've seen the profile. So I always try my best to get it in any time, in any possibility. And, probably that will be discussed later on. 3D ultrasound may be useful from that point of view. Cleft lip. Well, this is one of the most common malformation, of course. And I think that everyone who has some basic knowledge about fetal ultrasound knows that this will be diagnosed as a defect of the lip in the axial view, or as a defect of the lip in the coronal view, extending between the cavity of the mouth and the nostrils. And of course, unless you are very good images, unless your resolution is excellent, you may miss this condition. Because the anatomical derangement of isolated cleft lip is not much. And unless you really are able to demonstrate this little defect, can be, in the vast majority of cases, just a linear defect, you may miss it. But I think that you should never miss cleft lip and palate. Cleft lip and palate will appear like that. And in the axial plane, it is very clear that the entire image is disrupted, not only because you have the defect, but also because, as you can see very well, if you have cleft lip and palate, there is a disarray in the different portion of the palate that do not match anymore. There is much disruption. And of course, in the coronal plane, you will have a square-shaped defect. Usually cleft lip is just a linear defect, just a cut, but with cleft lip and palate, you have a large opening and much disruption of the normal anatomy. And I think that should not be missed. By using the axial view, you may judge how deep is the defect extending into the palate, and usually it is quite possible. As you can see in the image that you can see to the left of the screen, there is just one cleft in the most anterior portion of the palate, while in the image that is to the right, you can see that there is a huge gap that is extending all the way across the entire hard palate and probably soft palate as well. Usually this is quite easy to be identified, but remember that there are difficulties depending upon the fact that the fetus will tend to put the tongue most of the time inside the defect. You know, like when you have something wrong in your mouth, you have one teeth that is hurting you, your tongue will always go moving toward that. It seems that fetuses that have a defect on the palate have very frequent the tongue that is sticking. So that limits your ability to identify how deep is the extension. Of course, you may have unilateral cleft lip and palate, but also you may have bilateral. This is bilateral cleft lip, and in my experience, it is one of the most difficult conditions to be diagnosed. The findings are very, very subtle. I think that this is even more difficult to identify than unilateral cleft lip. That would be the appearance, and as you can see, the palate is perfectly normal in these cases. There is a normal array of the teeth buds, and only if you scan with the right angle, you will be able to see the two defects of the lip, the two cuts of the lip that are extending towards there. As you can see, it is very tricky. It is really very tricky. It's very easy to miss this in the second trimester. And this is the case that was a false negative diagnosis, and this is the image that we always obtain at 20 weeks. And when we went and saw the image, well, you can see that there was something wrong right there. But really, in retrospect, more than we only could see this clearly at 28 weeks. And as you can see, it is obvious when you see the face of the fetus, but you can imagine how difficult it could be to identify this condition antenatally. I think that when you're performing a routine examination, you should always be able to identify the cleft lip and palate, but cleft lip, whether it is unilateral or bilateral, very frequently you may miss it, because you really need excellent images to diagnose this condition. The findings are very, very subtle. Of course, this is the easiest condition to be diagnosed. It is bilateral cleft lip and palate, because in these cases, not only you have the clefts, also you have the central portion of the maxilla that typically tends to be dislodged, dislocated anteriorly. And as you can see, there is the three primary prominences that form the fetal face embryologically. They simply have not fused. And the central portion, the premaxilla, is displaced anteriorly. And this creates a very obvious image on ultrasound that looks like a tumor. In fact, I remember that David Nyberg in the beginning reported that he had received many of these cases that were referred to him because there was the impression that there was a tumor in the face. It was not a tumor, it was just the premaxilla, the central portion of the maxilla that was protruding, and of course that creates a major disruption. And these are the most severe defects, the ones that are most difficult to repair, and also the ones that have the highest likelihood to be associated with other malformation, chromosomal aberration, genetic syndromes, malformative sequences. The profile is not useful at all to see the cleft lip and palate if it is unilateral. As you can see, even if there is a huge defect, really the image that will tell the condition is the axial plane or the coronal plane. At times, if there is a very huge gap, you may have the impression, as you can see, that there is a hole in the center of the face, and this is the consequence of that the hard palate is disrupted. But of course, the profile view is very helpful when you have bilateral cleft lip and palate. So if you have, and sometimes it's not so easy to identify it, in general, if you have the impression that there is a cleft and there is protrusion of the premaxilla, you can be sure that that is a bilateral cleft. If it is unilateral, there is never protrusion. Well, cleft palate is a problem, of course, because repairing it is quite difficult. It has a lot of consequences, and it is frequently associated with other malformation. But in the vast majority of cases, in general, the rule is that we cannot see it. And the reason we cannot see cleft palate is because, in general, if you do the axial plane, as you can see in the first image that you have to the left, there is a lot of shadowing that is coming from the bones, and you don't see the posterior portion of the palate. Now, with modern machines, if you angle the transducer appropriately, you may get a view of the hard part of the palate, of the hard portion. And if you have an interest in this, I would recommend to you this paper that has been published recently by Jean-Michel Faure that describes the technique, which is a two-step technique. You first look at the palate with a tangential scan like the one that you can see in the middle. And normally you can see the entire extension. And you can see the appearance right there that is indicated by the arrows that Jean-Michel Faure calls the Batman sign, because it looks like a bat in reality. And if it is there, the posterior palate is probably intact. If it is not, then you can use 3D ultrasound, like you can see represented here. And with the use of 3D ultrasound, albeit it is a little bit of a tour de force, you can identify the cleft. I would say that on average, routinely, unless you are very experienced, this is simply a condition that you cannot identify at all. But if you have a patient that is at risk for this condition and you have the ability, then I'm pretty sure that you can diagnose the cleft palate, at least the biggest one. But clearly not for. We have found that the Doppler is useful if you have the time to wait for the fetus to breathe, because this is what happens under normal condition. As you can see, with sensitive Doppler, you can detect the flow of the fluids within the nasal fossa and within the mouth as well. As you can see, this is what happens normally. And you have fluid that is coming out of the nasal fossa and fluid that is coming out from the mouth. And this is what happens when you have a cleft palate. And as you can see, the flow goes all the way and joins the oral cavity and the nasal fossa are joined because there is a cleft in the palate. Also, you may notice that the tongue is in a much higher position than it normally happens when you have an intact palate. Those were the typical clefts of the face, the embryological defects, and there are other types of defects, and I think that you should be aware at least of two of these defects. Number one, the median cleft, which is, if you use the Tessier classification, is the cleft number 0, which is a central defect, a square-shaped central defect, and this is typically seen with holoprosencephaly. May be seen with other conditions as well, but they are very, very rare. In an ultrasound laboratory, of pregnant patient, usually the median cleft is seen with severe holoprosencephaly. So in general, you first see the holoprosencephaly, and then when you look at the face, but that's just out of curiosity, you will see that there is a central defect in the face. This is much more tricky, and this is a bad defect. It's a very bad defect. The lateral cleft, which is really not an embryological cleft, is more like a branchial arches problem. There is a cleft that is extending from one side of the face. It may be unilateral or it may be bilateral. And again, if you think about the scanning planes that we usually employ to evaluate the fetal face, you do not see this at all. There are very subtle findings on the 2D ultrasound examination that you can recognize, such as the asymmetry in the opening of the mouth, like in this second trimester fetus. And also, if you scan laterally, I hope that you can see this clip. You can see that there is something wrong with the corner of the mouth. Right there, as you can see. There. That is the corner of the mouth, and as you can see, there is some irregular opening. It's helpful to identify skin tags, because typically all cases that we have seen were associated with skin tags, typically located along the line of the defect. So if you see a skin tag, always consider that there may be this condition, particularly if it is on the lateral cheek. And this can be a very severe anomaly because not only you have a cleft of the soft tissue, but also you have an hypoplasia of the mandible, and it can be awfully difficult to reconstruct. Of course, the best approach for this condition is the 3D ultrasound, and I guess that we will hear about that later on. A few data. What is the present situation? Well, if you look at the last data that were available from the EuroCat, it would seem that perinatal diagnosis of cleft lip and palate occurs in about 50% of the cases, and most of the cases were not diagnosed in early gestation. There are more recent data coming from the Netherlands, and as you can see, the epidemiological survey that has been performed in the Netherlands suggests that perinatal diagnosis in those countries, because there are many variations, is much higher than that. It is in the range, as you can see, of 80 to 90%. One important point is that, there is a problem of politically correctness about cleft lip and palate, because you get the impression, cleft lip and palate is something that can be corrected. It is an aesthetic problem that can be resolved, while if you diagnose that in utero, parents may decide that they do not want such a child, and they will decide to terminate the pregnancy. That is not really the rule. As you can see, prenatal diagnosis of cleft face is important because this is a condition that is typically associated with other malformations that are quite frequent. But if you look at the case with isolated clefts, as you can see, the request of termination of pregnancy is very rare, 1 to 5%. 99% of parents, after the diagnosis of an isolated cleft, will decide to continue the pregnancy. Just a few things about micrognathia. Micrognathia is relevant for the point of view of prenatal diagnosis because, of course, there are many variations, and there are people that have very small chins, people that have large chins. The problem is that when you diagnose it in utero, this is very frequently associated with multiple anomalies. This is one of the very few cases in which micrognathia was isolated. It was one of my first cases. It was a familiar case. And this infant had no other problem apart from the small chin and the problem in the palate. But prenatal diagnosis was useful because, in fact, when the child was born, the chin was so small that the child could not breathe properly. So there was a request of an intervention. And this is some other cases coming from my collection of infants with microneuralgia and many different types of potentially severe malformation. Well, one should distinguish between microneuralgia and retroneuralgia. Microneuralgia is a small mandible. Retroneuralgia is a mandible that is displaced posteriorly. Frequently, the two conditions are concomitant. They are difficult to be differentiated antenatally, that for sure. How do you diagnose microneuralgia? Well, I would say that the profile view is the most important image of all. And the main finding is that when you have microneuralgia, you have an overbite. That is the most important thing. The overbite is what leads you to suspect that the chin is small. And sometimes the condition is so evident, so obvious, that you can diagnose it just with this image, and even very early in gestation. I'm invading a little bit the field of Waldo, that we'll discuss this later on, just to tell you that sometimes it is an early finding, and it is so obvious that the image speaks from themselves. Of course, this is mostly a subjective diagnosis. And people have tried to objectify it, and it is difficult, of course. There have been many different parameters that have been proposed over time, direct measurement of the mandible, but that is difficult, because the shape of the mandible is not geometric. It is difficult because these are small measurements, and they are difficult to obtain. So the prediction interval is so wide, is so large, that it's difficult to make the diagnosis. Or you may use angles, but angles in general are the worst from the point of view of biometry, because they suffer from a terrible systematic error in identification. I do not know if really biometry is more effective than simple visualization, because there are many different parameters, and it seems, from my point of view, that those are the type of things that work good for the ones who have invented that. But when other people have to use them, or you have to introduce them in clinical practice, they do not work very well at all. But I think that this is a trick that you should remember. And this was a very brilliant observation that was done many years ago by Dr. Moshe Bronstein. And I find that it is really very brilliant. And this has been almost completely ignored. But a few years ago, there have been a few papers that were discussing the same things, even from the point of view of magnetic resonance, because, of course, magnetic resonance can be useful to diagnose facial malformation. The bottom line is the following. The development of the tongue is independent from the development of the skeleton of the face. So normally the tongue, but when there is a poor development of the mandible, the tongue is too large for the oral cavity, and it tends to be displaced posteriorly. What is important is that, of course, we know very well, if you have microneuralgia, you have difficulty in breathing. You may also have extreme difficulty in breathing. If you have microneuralgia, you have the following, and that is the reason why very frequently you got a polyhydramnios. And we can see the tongue. And typically, if you have a very severe microneuralgia, the tongue tends to be displaced posteriorly and obstruct the pharynx. I will try to demonstrate this to you. And as you can see, this is what happens normally. And as you can see, the tongue is normally contained within the oral cavity. And as you can see, the tip of the tongue normally reaches the level of the mouth opening. And you can see very well the airways that contain fluid. And you can see also the soft palate. But when you have this poor chap here is desperately trying to keep the mouth inside the tongue. As you can see, it is really fighting. And you can see how the tongue does not reach the opening of the mouth. And again, these are two different cases, a normal fetus and a fetus with micrognathia. And you can see that the tongue does not reach the opening of the mouth because very simply the mandible is too small and it tends to be dislocated. If you have the impression that the mandible is small, you can take a look at the fetus while it is swallowing. And if you see that there is a posterior displacement of the tongue and obstruction of the pharynx, you can be sure that that is micrognathia. Not only that, but that it is severe. And most likely, the fetus will develop polyhydramnios throughout gestation, will have problems in breathing, so will require an intervention. And because if there is not room for the tongue inside the mouth, that will prevent the normal development of the palate and will form a typical central defect in the palate, a U-shaped palate that may need to be corrected. Conclusion, most national and international guidelines recommend visualization of the fetal lips, so we have to adapt to that. Typical cleft lip and palate is rapidly recognized. Cleft lip is more difficult, and I expect that, of course, false negatives can occur. Cleft palate is not amenable to sonographic diagnosis, but for very expert sonologists that are examining patients at increased risk. If you decide to include a view of the fetal profile, the precision of clinical diagnosis of micrognathia, of course, is unknown. I thank you very much for the attention, and of course, if you have any question, I will be delighted to answer them.
Thank you, Gianluigi, for a really wonderful account of how to detect these abnormalities. And there are many questions coming through. And I've got a few questions from Ramon from Spain and from Chanda in India about the split uvula sign or the equal sign, demonstrate the normality of the uvula, and whether in your experience this is a useful marker, and whether perhaps using this marker improves also the detection of isolated cleft palate.
Well, I wonder if you can see the image. Can you see?
Yes.
Well, of course, if you look at the profile view of the fetus, you can see if you tilt the transducer appropriately, the soft palate that is moving, particularly when the fetus is swallowing. And if you have a defect there, that is going to miss. So profile view may be helpful in these cases. Realistically, do I believe that in a routine ultrasound examination you can pick up this? Well, honestly, I don't know. In general, I would say that unless someone is extremely expert in fetal ultrasound, that is going to be a relatively minor proportion of all cases, cleft palate is really not amenable to the prenatal diagnosis.
Mm-hmm. So, and that goes to Dr. Cleva's question from Brazil, Dr. Cleva Santos, who says, is there really a particular image or a particular view that I can secure that will essentially rule out a palatal cleft, an isolated palatal cleft, especially in particular the soft palate?
Well, I would recommend to you the approach I'm wondering, where am I going? I would recommend to you this paper, which I think is the most relevant one. Okay, Jean-Michel Faure on prenatal diagnosis, and I think to me that is the most rational approach to the solution of this problem. Of course, something that cannot be overcome is the fetal position. Unless the fetus is not in an adequate position, you will not be able to get the image that you can see there. This image clearly, it was seen from the experience of the group of authors and mine as well, rules out at least a defect in the hard palate. From the point of view of the soft palate, is more complicated. Can you obtain realistically these images in all patients that you examine? I would say no, it is not possible. Unless you schedule your patient for 1 hour long examination, which is not realistic.
And that's a question that Vincent Mueve has from the United Kingdom. He said, look, most of the times the fetal position makes it really difficult to exclusively scan, to conclusively rule out a cleft palate. What do you feel is an acceptable, I guess, policy when the fetus is in that unfavorable position? Do we just accept that in a proportion of patients we don't see that?
Well, I
guess in the same way as, we would not accept any longer that you would not have adequate views of the outflow tracts just based on the fetal position. At what point do we say this is a must-have rather than a nice-to-have?
Well, my view is that we should not look for routinely for cleft palate in all cases. Because, of course, it is an anomaly that is relevant, there is no doubt of that, but it is not so frequent. And if you aim at obtaining the type of image that is displayed here in all cases, you will simply fail because of the quality of the images that is not going to be that good in all patients because of the position of the fetuses. And you cannot realistically schedule patient for hour-long examination. This is simply impossible. So realistically, I would say we should go with the national guidelines that are fine to me. And our main goal is to identify the cleft, lip, and palate. That is the relevant defect.
Fantastic. Gianluigi, thank you very much. We've got some people who have joined the panel today, and Baschi wanted to just very quickly share one image. Baschi, I think you can share your screen.
Thanks. It says I cannot, but okay. Here it is. Gianluigi, thank you very much. It's nice to see you looking so well, and thank you for that presentation. I have to say that I agree with almost everything except for one, which is the equal to sign. This was published in 2010 by Wilhelm and Borgers. I would presume Germany or Austria. Forgive me if I've mixed that up. And now we've been using it systematically at George's for the last 2 or 3 years. Now, Saha might say that she doesn't think that we're very good at it, but the beauty of this sign is that you can see the nasopharynx and you can see the uvula, and we can pick it up in 9 out of 10 cases. And of course, we only do it when we see a cleft lip or a micronathia, but it's a fairly straightforward sign. When you come down from the cerebellum, you come into the back of the nasopharynx, you see the equal to sign there. And if you go down too far, you see the vocal cords. I must admit that even most of the juniors that work with us now can pick that up relatively frequently. So I would urge you to try and look for the equal to sign. I think Wilhelm and Borgers are very underrated, and they should be applauded for having noticed this.
Thank you, Baschi, for your comment. Prashant has a comment.
It's about, the same thing. If you don't look at a 2D imaging for that equal sign, a 3D volume will help us in seeing the uvula fantastically. It looks so beautiful I'll show that those images during my presentation, how brilliantly you can evaluate your uvula, and even bifid uvula can be picked up very, very nicely. Only isolated bifid uvulas. I'll show them, but we'll take it later on today.
Thank you. Gianluigi, I don't know if you had any comment on the images that Baschi was showing. I tend to agree with you, Gianluigi, that routinely screening for cleft palate is going to be difficult to achieve for the majority of our delegates. People who are technicians or sonographers who scan fetuses day to day. But I suppose what the point Baski is making is if we start including additional signs, we may start becoming more expert even during our basic screening scan. Gianluigi, I don't know if you had any comment on that.
Oh, yes, of course. That is the rule of prenatal diagnosis. You push and you push and you push. And of course, by pushing, you make progress. That is the point. I am not that familiar with the equal sign, I have to admit. And I have not been very successful in seeing that. And I have been wondering, when in many cases I don't see it, should I go into the difficult process of finding out whether there is a cleft palate or not anytime that I see it. But if you have that type of experience, that is, of course, remarkable. That is our field. There is always someone who is pushing, and it is by doing that that we make progress. Now that we say that you can see it 9 times out of 10, which is remarkable to me, but I have to believe you, then I will go and try it myself.
Fantastic.
Different approaches.
This is such a great avenue for disseminating great information. I'm going to invite Tessa, but Saha had an important point. Saha, you mentioned that the equal sign not only important for routine screening, but also particularly if you see in a targeted screening. I think. Do you want to make your point, Saha?
I don't think it's important in routine screening because it's not good enough, quite frankly. But if you've got a fetus with a small chin, the risk of a cleft palate's very, very high, and you should look for it. And if you can't see it, you should still err on the side of caution and suspect that there's a cleft palate. Or if you find a heart defect that's consistent with 22q, it might be worth looking in that situation. But so not routinely, but if there's a good reason why there might be a cleft palate, I'd look then.
Thank you so much. Tessa, it's such a pleasure to have you online. Tessa is a consultant in medical genetics and does a clinic with me and with Baski as well, and Asma and the team at St. George's. But she's a very popular geneticist, so she's kind of also working at King's College with Kypros at the Harris Birthright. She's also working at the Brompton because she also has a special interest in inherited cardiac conditions. Thank you, Tessa, so much for joining today. We've already had lots of questions about genetics, and I'm going to hold them for the end of your talk because I suspect that quite a few of them you will answer through your talk. But I've got the questions rolling in. Tessa, thank you.
Can you hear me, everybody? Is that all right? Is that all right? Can you hear?
Yep.
All right. Okay. So thank you very much, Aris, and everybody else for asking me to talk about cleft lip and palate. And I will reiterate, and I work very closely with Saha, we feel that you miss cleft palate quite often. We don't seem to be able to move on. All right. So what is the problem that we really are looking at with this? And of course, from a genetic point of view, 70% of cleft lips and cleft lip and palate, and I'm talking about in this case, have no associated syndromes associated with them. It's an isolated abnormality, and you want to be reassuring to those patients that everything is fine. Now, I don't know why we're not moving on. Sorry, it's not moving. Ah, yes. So we, as we have, platelets are rarely identified, but they have a much higher association with genetic syndromes. So although we don't pick them up, we can't see them nearly, they're more relevant genetically. So we are very dependent when we're thinking about cleft palate syndromes on associated abnormalities. And to a certain extent, so are we with cleft lip and palate, because we do not want to worry every single patient. So we know that the Pierre-Robin syndrome or micronathia is very frequently associated with cleft palate. And it's why I asked Aris if we could talk about micronathia as well, because the genetics are very, very closely associated with the two issues. So the overall incidence, it seems to vary quite a lot around the world, with 1 in 600 to 1 in 1,000 in the UK. 75% are unilateral, with left greater than right, and males have a greater incidence, probably 2 to 1 male cleft lip and palate to the females, and it's commonest in Asian and American Indians. In cleft palate, the opposite is true. The females are more often associated in males. The overall incidence is less, but there is more that have an associated syndrome. Now, twin issues are always, twin studies are always very useful when you're looking at the genetics of these cleft lip and palates. And even in monozygotic twins, the concordance is relatively low. And I'd like you to just point out why it is even lower with cleft palate, even though there is a higher genetic burden than it is with cleft lip. And that's probably because cleft palate is very much a midline abnormality, and it may be associated with the twinning process itself. So that it may be why you get poorer concordance. Not surprisingly, with dizygotic twins, there's a much lower concordance, but still much higher than the general population, indicating that there is, without doubt, a genetic component. There are a few teratogens we know, with obviously with roaccutane use for acne, a well-known teratogen, anticonvulsants, and people on anticonvulsants are told to take higher doses of folic acid. There's not such a strong association as obviously there is with spina bifida. Alcohol has a little bit of increased relative risk, as do steroids, and there is potentially associated with hypothermia, but not any specific fetal infection. And of course, that is important. Now, we talk about 70% of cleft lip and palate being isolated, but over 400 syndromes now have been associated with either cleft lip and palate or cleft palate. So masses and masses of them. And don't worry, I'm not intending to cover these syndromes. I'm just going to pick out a very few, the commoner ones, and how we are potentially managing these now more frequently. So the first thing is to remember that if you've got a midline cleft lip and palate, this is a totally different sort of problem than the unilateral or the other side. And that is because you must consider holoprosencephaly and alobar and semilobar holoprosencephaly. You will manage to identify on ultrasound, and you will easily slip up even in the first trimester, where sometimes these are picked up, and you may pick up the holoprosencephaly before you've actually even looked at the cleft lip. But the lobar holoprosencephaly you will miss on ultrasound. You may pick up an absent septum pellucidum, but it will require you to do an MRI scan. And I think advanced genetic investigations for any midline cleft is utterly justified. So if there's a non-midline cleft lip and palate, what other things am I really interested in you looking for? I'm very interested in the growth of the baby, not obviously relevant at 12 weeks, but later on at the 20-week scan, this is absolutely essential. The limbs, there seems to be quite a strong association with limb abnormalities. The presence of hypotelorism. We know that babies with Smith-Lemli-Opitz syndrome can have sex reversal. So if you do a chromosome test and you find the sex, it is always make sure that it's concordant with that of the chromosome analysis. And we look for congenital heart disease. Obviously, this is particularly important if you're thinking about 22q, but you'll probably may miss the 22q if it's just a cleft palate. So the other thing that I'm very keen on looking about is the family history, because there often is a family history in some of these syndromes. Now, even with the holoprosencephaly, which you would probably say has a very low chance of having a family history because it is such a devastating condition, that isn't always the case. You may have a family history of an intellectual disability or a single central incisor. And one of the things that I would always ask with a midline cleft is there anyone who's had a single central incisor? And remember, people have dental treatment, which will hide this abnormality. And it's very easy to ask about this and a family history of other things. And we had a family where there were two sisters who had babies with holoprosencephaly. They both had single central incisors, and we found a mutation in sonic hedgehog. So midline clefts, in the absence of a chromosome abnormality, there's a 12 to 25% chance that you will find a genetic syndrome, and there may be a high recurrence risk. So if you've got a cleft lip and palate, what are you particularly going to be asking to look at from a family history? Well, obviously, cleft lip and palate. We'll talk about lip pits. Please ask about poor hair growth, unexplained scars, and I'll come back to that, and ectrodactyly. So there are major chromosome abnormalities associated with cleft lip and palate, and not surprisingly, if one of these are identified, then the prognosis is absolutely dire. Probably the two commonest are Wolff-Hirschhorn syndrome, which is 4p minus, and trisomy 13. So with trisomy 13, I don't need to tell this audience. You can also look for anophthalmia, renal agenesis, congenital heart disease, and the multiple abnormalities. So it's very, very rarely that you would come across isolated cleft palate. Triploidy, again, can have bilateral cleft lip and palate, and you're particularly looking for small for gestational age, occasionally associated with spina bifida. And with Wolff-Hirschhorn or a 4p minus, you might get congenital heart disease, and they certainly get small for gestation. Greek helmet skull, but shaped head, but I really think that would be excessive to expect you to pick that up antenatally. So what about a family history with cleft palate? As I said, it may be suggested by a micronathia, and frequently there is a family history here, and Stickler syndrome, which is associated with severe myopia, but the palate, the micronathia grows out, and actually you have to ask about this history because the affected parent may well not anymore have a small chin. Treacher-Collins syndrome, which I will be talking about a little later on, again, can have a very, very mild phenotype. And apparently the zygomatic arch, an X-ray of the zygomatic arch, is the most sensitive sign of gene carriage. As far as chromosome abnormalities associated with cleft palate, we've already mentioned the 22q11.2 deletion. You may look for this if there is a family history. If one of the parents has a nasal quality to their speech, you could be really clever and look for a cleft palate. But not surprisingly, 80% of these children will have some form of congenital heart disease, and you'll be much more looking at that, and potentially also at the thymus. So I just want to take you through a few cases, just because I think these can be very illustrative of what we should be looking for. And so if you, often micronathia can look more significant at the early scans. So the first trimester scan, you may pick up a micronathia, and you're not quite sure whether this is going to grow out or it is going to become more significant. And you can all see this is a very significant micronathia pricked up in the first trimester. And actually this didn't improve. And so by the second trimester, we can see that this baby has got severe micronathia. And you would very much suspect that this has got a genetic syndrome. And at this stage, we were not able to do a lot of tests because it was a few years ago now. And the array CGH was normal. But the major concern at this stage is how are we going to manage a delivery? Is this patient going to need an exit procedure? And what is the underlying cause? So this baby was born, and in fact was born in relatively good shape. It had a nasopharyngeal airway inserted, and a few days later had a cardiac or a respiratory arrest. Resuscitation was performed, and a chest X-ray was performed. And the resuscitees were very, very shocked to see that they had caused so much major damage to this little baby during the resuscitation. Of course, they hadn't. This baby had got multiple rib gaps. And this immediately gave us the diagnosis of this condition, cerebrocostomandibular syndrome. And ever since, I have asked my fetal medicine colleagues to look for interrupted or rib gaps. I've not seen a case since, but always look for rib gaps when you have got a small chin. Now, poor growth is a very, very important sign. I've already mentioned it as far as Wolff-Hirschhorn syndrome is concerned. And this was a baby that was referred up to the fetal medicine unit a few years ago now. And the baby was growing poorly, but there was no other abnormalities identified. One of the conditions we always think about, and there was a very good reason for thinking about this syndrome in this particular family, and we were looking at the fact that there was quite a small chin. It is not an obviously very small chin, and we're looking at this bit of the face as well. And here we are looking at a baby with Cornelia de Lange syndrome, where they have a small chin. And this is an extremely important condition because it is associated with a very severe, often mental retardation or intellectual disability. A lot of these babies we pick up because they've got limb malformations as well. But in this case, there was no limb malformation, but we were extremely worried about this because actually there had been a sibling affected. And so could this be a recurrence? And indeed it was a recurrence. And we got this because of the facial features. But the facial features are difficult. And here was another case that we had a few weeks ago. And I think actually when you look at this philtrum here, we've got a more significant micronathia under this condition. But again, it may be the facial features all look a little bit like Cornelia de Lange because of the small chin. And this baby on fetal exome was found to have a MED13L mutation, which there is no way you're going to be thinking about those sort of conditions without genetic testing. Now, another issue that we look at is you can have this bifid uvula. And I think it is difficult because there is no way on routine testing that you would be looking for this, as we've already been discussing. But there is this condition, Loeys-Dietz syndrome, where you get arterial tortuosity. You can get other fetal abnormalities. You can get talipes, and you might get some form of heart abnormalities. You might get a dilated aorta. And this is important for two reasons. One is it is a serious condition. These are intellectually, delightfully normal people, but they have considerable health difficulties. And if the mother is a carrier of this condition, and again, you may not recognize that this is the case, she may well rupture her aorta during labor. And so I think sometimes we can actually, by identifying a condition in a baby, help a parental diagnosis, and we've done this on a number of occasions. But if you see other abnormalities that you might think of this particular condition, or there is a family history of sudden death or anything, think about Loeys-Dietz syndrome, and they can have overt cleft palates, but they're not going to have overt cleft lips. So I mentioned Treacher-Collins syndrome, and normally you will be picking this up because there is a family history. And if there is a family history of Treacher-Collins syndrome, you are only concerned about a recurrence if it is a severe form of Treacher-Collins. So even if you know the mutation, it's not actually particularly helpful, because actually you want to know if this baby is going to be severely affected. So we can look again at the chin. We can look at the ears, and you can, in fact, see facial features of down-slanting palpable fissures, which would be suggesting a severe form of Treacher-Collins syndrome. So I think that in the presence of a family history, we can look for the severe forms of Treacher-Collins. And in the absence of a family history, if we see a micronathia, we will be looking for facial features. And I think 3D scanning is very useful in these particular abnormalities. If we go across to the cleft lips now, probably the commonest cause of inherited cleft lip and palate is van der Voorde syndrome, which is associated with mutations in this gene IRF6. And they classically have these lip pits. And the serious form of this disease, even within the same family, is something called popliteal webs, which are a web. And in the popliteal region, it can leave these children with just a scar, but it can be a much, much more serious abnormality. And I've seen one of my patients who had a double uterus. She had a severe scoliosis, and actually was very seriously affected with this condition. So although if you see this and you've got a family history of it, a very careful scan is absolutely well worth it. And you don't just stop saying, oh, well, we know what this is van der Voorde, this isn't something we worry about, let us continue. Not all babies have the, not all affected people have the classical lip pits, as you can see with this little jolly little person who is actually doesn't have the lip pits, but she has a van der Voorde mutation. And parents might have had surgery for these lip pits. And if it's done when they're very young, they're not going to remember they've had surgery. And so you might have to prompt them to ask about this diagnosis. This was a little girl that I saw actually very recently, and she did have an IRF6 mutation, but she also had these ankylar blepharon, or these synechia in the mouth, and I'm not sure if you guys could have a go at picking these up. Her father had exactly the same, and this broke spontaneously. So I talked about looking particularly for limb abnormalities, and ectrodactyly, ectodermal dysplasia and clefting is an important cause of cleft lip and palate. So always look at the limbs. It is always important to examine the parents. This is all due to mutations in P63. The ectodermal dysplasia may not always be present, but there is very frequently a family history, but each member may be very variably affected. But this is, again, a condition with an autosomal dominant inheritance, which actually, again, has a very good prognosis, and patients often do extremely well, even with these problems. The last condition that I'm actually going to mention specifically is a condition called Roberts syndrome. Now, this is a condition associated with severe limb abnormalities, with can be bilateral cleft lip and palate, and you may not just get isolated limb, upper limb abnormalities. You can get phocomelia, where you can get almost normal hands and feet. You can get this sort of oligodactyly, as you might see in Cornelia de Lange syndrome. And these babies can be, again, severely growth retarded. But you normally here would get a cleft lip and palate, whereas within the Cornelia de Lange, you would only get the cleft palate or the and the small small for gestational age. And Roberts syndrome is actually specifically associated with this condition called chromosome puffing. Now, cytogenetics is really now a dying specialty. We do virtually everything now with molecular genetics. And so people have probably forgotten that this is a test that can be undertaken. And we would now look for a mutation in the gene ESCO2, which is associated with Roberts syndrome. Very important. It's an autosomal recessive disease. Some of these children are okay, and well, they're not okay from a physical point, but many die in the neonatal or early postnatal period. So I just want to bring some conclusions to this talk about how you can be helped when you are seeing a patient with this. So if you have a midline cleft lip and palate, you need to consider looking at the brain and consider a brain MRI in the third trimester to pick up lobar holoprosencephaly. Always offer invasive testing to look for a chromosome abnormality, which are specifically associated with this. We're not yet doing it routinely, but maybe we will be in the near future. I think that if you've got a bilateral cleft lip and palate, you should always also offer an invasive test, because there seems to be a higher degree of chromosome abnormalities and genetic syndromes with the bilateral cleft lip and palate. A detailed family history, which you guys probably haven't got time to undertake, but certainly it's worth it with the midline and the bilateral cleft lips. And if you've got any concern about other ultrasound abnormalities, maybe we should be getting genetics involved. I'm a little bit worried to say that, because I'm not sure we want to see all unilateral cleft lip and palate. And also, by referring to genetics, you actually upset patients, because they believe they think you have got a genetic abnormality, which of course we know in 75% of cases you haven't. You need a detailed growth scan. And with an anomaly scan, we need the limbs particularly carefully looked at. And I think it's a particular one for a 3D scan. And I think it's worth considering exome sequencing in those with normal chromosomes if you've got associated abnormalities. I don't think I've got anything else to say, but I would be very happy to answer any questions. Hundreds of genes that I haven't mentioned, but I know that you'd have lost the will to live if I started mentioning all of those.
Thank you. Thank you. That's brilliant. Please leave that slide on, because it answers quite a lot of questions that have been popping through the web. And one of them is, provided there's no other markers, so you've done an ultrasound scan, the only thing you see is what looks like an isolated cleft lip and an alveolar ridge. What do you quote as the incidence of chromosomal or genetic risk factors in someone where you've done a really nice detailed scan and nothing else is seen? Should we be offering an invasive test to these women, or is the risk low enough not to do that? Because it's the majority of cases where we've got nothing else to be seen.
I think, Aris, and I think all our, what you are offering, and I know they're doing it on the Harris Birthright Unit as well, is that how you offer an invasive test is you sort of, if you think they really should have an invasive test, you say, I really think that there could be an associated abnormality. We offer an invasive test because we feel we should, but with an isolated abnormality of a unilateral cleft lip stroke plus or minus alveolus, then the chances of finding an abnormality, I quote that over 70% are isolated, but I think in that group, we're probably talking about over 95% are isolated. So I think it is a low risk. And if patients are happy to accept a small risk, I don't think they all need invasive testing.
Fantastic. So midline, definitely, we would counsel towards, as we would for bilateral, or if there are associated abnormalities. If it's true, if it really looks isolated, yes, you offer it, but the chances of being affected are small. That's really helpful, Tessa. I've got another question from Sharif in Tunisia. It's a clinical scenario, and this is a lovely question. Look, I've got 3 sisters, and they've got lots of people in the family. There's a brother that's affected, there's an uncle that's affected, and one of their kids is affected with a cleft lip and palate. I can offer them genetic testing, but what am I going to test for?
Well, I would always, if you've got a patient and not a fetus, you can actually examine these patients. So, we can examine the patients, we can look for lip pits, we can look for limb abnormalities, we can look for hair abnormalities. But of course, if there is a strong family history and everybody is actually fine, that in itself is very reassuring. So to a certain extent, genetic testing becomes less important. So my issue is if it is isolated, now there are multifactorial genes, yes, you probably put them on folic acid. You could do an exome, and of course that's what always our defaults these days. But I think you would want a full examination. And IRF6 with the Van der Voorde are the commonest. There is an X-linked form of cleft lip and palate, so you'd make sure that wasn't the case. And of course, if you have a highly consanguineous population, you've got to be a little bit careful there. So I don't think without examining them, you can really say what you would be thinking about doing.
Okay. And Tessa, one more question now, not about cleft lip and palate, but about micrognathia. So if you've got micrognathia, nothing else to be seen on ultrasound, again, the question is, what is the likely risk of an underlying chromosomal or genetic condition?
I think very high. I think these ones, a very significant micrognathia, I think you've got probably up to a 70%, even higher chance of an abnormality. Most of these will not be associated with an intellectual disability, but they may well be very significant. Again, a family history, thinking about myopia and Stickler syndrome, and Treacher-Collins syndrome. So I think a micrognathia is a much more significant genetic abnormality.
Okay. So we've had the discussion with the woman, and she's decided to have invasive testing. Should she see the geneticist beforehand in order to decide what genetic testing should be done? Obviously, we'll do the major chromosome. Depending on the findings, would the geneticist want to see them in advance to decide what targeted genetic diagnosis one might want to pursue?
Well, obviously, you need to do the qF-PCR first. Are the commonest abnormality that we're going to see on the numbers side, but actually these micrognathias are very significant genetic abnormalities, and obviously that's the prognosis underneath. So we do see these. I think the only issue that I would say, some of them grow out. So between the 13-week and the 20-week scan, or the 12-week to 20 weeks, Simon probably wouldn't be needing a 20-week scan because he's picked this up by about 8 weeks at this stage. He's way ahead of the curve. But some of these get better. And as I said, I think we can be destructive. Seeing a geneticist suggests trouble, doesn't it? And it suggests you're going to be having something very major. And so if we are absolutely convinced, like we were with that first patient I showed at 13 weeks, that this was very severe, scan, because I think we will then have some more idea of how significant this is. And we've excluded potentially all the chromosome abnormalities at that stage.
Yes, I'll just read out one comment here from Rabbi, who's online. Thank you for joining, Rabbi, today. He says, really excellent, Tessa. Both you and Saha mentioned about heart abnormalities. And he says that we must remember that in 22q, it's often a submucous cleft, which is really impossible to see on ultrasound. But if you do have a cleft in the heart, also remembering to think of Charge syndrome and Kabuki syndrome as well.
And I think they would be Charge and Kabuki are two but they're very much more on the congenital heart side. So if you pick up a congenital heart, the cleft palates you certainly see with Charge and Kabuki, but again, they're very difficult to pick up. And so the biggest clue would be congenital heart disease. And I agree, and it's really why I skipped over 22q, because I really, really don't think you'll ever pick it up. However good you are, you're just going to miss it.
Thank you, Tessa. Lots more questions, but I think we're going to move on because it's very late for James in Melbourne. And there's many questions also, incidentally, just briefly on first trimester diagnosis, 3D, 4D, what sort of 3D, 4D you do. Please hang in there. Walder will talk about first trimester diagnosis, and Prashant will cover all the 3D, 4D and how to best visualize. But Simon.
Thanks, Iris. It's a pleasure to introduce our next speaker, James Leon, who'll be talking from the surgical side, postnatally, the plastics and repair of facial clefts. James is also from Melbourne, a local like myself. I'm trained in plastic surgery in Australia, having completed a microsurgery fellowship in Essex in the UK. He's the adjunct clinical associate professor at Monash Health and has private rooms at Dandenong. His special interests, why we have him here today, are repair of cleft credit. So it's a great pleasure, and thank you very much, James, for joining us this evening. I'll hand over to you.
Thank you, Simon. My name is
James, we can hear you very well, but we haven't got any slides at the moment. I don't know if you're already sharing.
Okay.
Just need to share screen.
Well, I did press that button. Let me just go back again.
While James is working his way through the IT side of things, Tessa and also for Gianluigi, I question whether retronathia, whether we should try to distinguish between micronathia and retronathia prenatally, and whether that has any sort of genetics implication in terms of counselling. Because I know certainly we all university call, when we see an overbite, we go straight to a diagnosis of micronathia. But is it a case where the jaw is in fact of normal size, but there's actually a retronathia? I don't know if Gianluigi could comment on that. And maybe Tessa, from a genetics point of view, it's important to distinguish between the two. I think James has got his presentation up, so maybe we might leave that question to the end. I think you're good, James. We see you now. Just need to unmute your mic and then you're good to go.
Okay, back to the cleft care. As you can see, multiple teams are involved with the delivery of cleft care. More than 12 different units are involved. Suffice to say that this is a really big team effort looking after cleft patients. A little bit about the genetics. As we were in 1 to 2 out of 1,000 newborns, 70% of infants with cleft lip and palate are non-syndromic, and 50% of infants with a cleft palate, isolated cleft palate, is also non-syndromic. The family history and different risk factors that have been discussed previously. Interesting facts about cleft lip. The left side cleft is the most common, followed by the right side, and bilateral is the least common. We see one bilateral cleft lip out of about 8 to 10 cleft lip. The combined lip and palate cleft is more common than isolated cleft lip and more common than the isolated cleft palate. So we know that the lip and palate develop separately, so the cleft lip and cleft palate can be isolated or combined. The cleft palate forms from the failure of the palatal fusion, and the cleft lip is formed from the failure of fusion of the medial nasal and lateral nasal and maxillary processes between the 5th and 6th weeks of gestation. Cleft care occurs from prenatal, and it goes all the way to the patient when the patient's about 18 years old. So when we see the patients at the prenatal appointment, we explain to the patients the incidence of cleft. Perhaps we explore the risk factors and family history. And we go through slowly all the key issues, such as feeding, when we do the lip repair, when we do the palate repair, the audiology and middle ear effusions issues. We talk about speech development, language development, and then we come to dental care, early orthodontics, alveolar cleft repair, and later on facial rebalancing surgery, and finally septal rhinoplasty to correct the nose deviation. The first 2 years is probably the most busy. We talk about feeding. Isolated cleft lip patients can breastfeed because they can form a seal and they can produce a negative suction to breastfeed. In cleft palate babies, these patients cannot generate a suction reflex because they cannot form a seal around the breast. So in these patients, we provide them with special bottles with longer teats with a single one-way valve. And there's different types of bottles available in the market. They range from Pigeon, Haberman, Dr. Brown, and there's about 6 different types of bottles. Sometimes the parents and the babies have to try different bottles to find out the most suitable ones. The other problems about feeding too is due to the inadequate attachment and inadequate intraoral pressure, they take longer to feed, they get inadequate intake, and the baby gets frustrated and exhausted. To the different types of cleft lip, they range from a minor notch on the left-hand picture to an incomplete cleft lip in the middle and a large unilateral cleft lip that goes all the way through into the nostril, through the alveolus, and distorts the nostril is asymmetrical. The left alar is widened and stretched. The nose is deviated to the right side, and the septum is also obviously deviated to the right side. You could have a bilateral incomplete, or you could have a complete bilateral lip. And sometimes you can also get a combination of incomplete on one side and complete on the other side. Cleft lip surgery is performed between 3 and 6 months. The two most common type of repair for unilateral cleft lip is the modified Millard and Fisher, and the Millard-Mulliken repair is for bilateral cleft lip. Slide, we show a young girl, 6 months, with an incomplete right-sided unilateral cleft lip. And you can see there's a cleft in the alveolus and there's also a cleft palate. This is the child 12 months after repair. And this is the child at 2 years after repair. The lip symmetry is good and the shape of the nostril is not too bad. And it's quite a good aesthetic results here. Much bigger cleft lip. This is a complete cleft lip on the left side. It goes all the way through to the alveolus, and there's a cleft in the palate. You can see the nose is distorted. On this worm's view, you can see the maxilla on this side is quite flat and depressed. The shape of the nose is also tilted to one side. This is a child at 11 months post-repair. And this is a child at nearly 3 years old post-surgery. A bilateral cleft lip. This is a child at 4 months. It's got a large protruding premaxilla or prolabium. There's a complete cleft on both sides. This is a child at 9 months post-repair, and this is him at 4 years. Another child, bilateral complete cleft lip, repaired at 13 months, and this is him at 4 years old. You can see that the columella on the repaired lip and nose, this bit is still very short. And most of these kids, when they turn 16 or 18, they need a septal rhinoplasty to lengthen the nose and to give them better tip projection. In a bilateral cleft lip with a prominent prolabium, I just want to point out to you how this part, the premaxilla or the prolabium, is sitting anteriorly and very anteriorly projected. It makes the repair more difficult because we have to bring the lateral lip element with the muscle to come all the way across and provide a seal. So this is the same child, a little bit older, and this is the child after a bilateral cleft lip repair. I just want to point out to you this child with a large cleft lip on the left side. The maxilla on this side is depressed. The nose is deviated. The septum is deviated. And the cleft lip deformity, the cleft nose deformity is a very difficult deformity to fix. We have managed to repair the lips very well, but when you come to the last stage of fixing the nostril and the shape of the nose, it's still a difficult challenge for plastic surgeons. The same child at 5 months post-surgical repair, the lip symmetry is good. It's nicely repaired, but you can see here on the nostril and the shape of the nose, the maxilla on the left side is still a little bit depressed. And as the child grows, the nose will deviate further. We also use taping and molding. So taping and molding is used to bring tissues together and to make repair easier for us. Same patient with a protruded prolabium. It's difficult to bring the two lip elements on this side here to come across to repair the cleft lip. So in this patient who has tolerated the taping quite well, we brought this the both elements of the lateral lip closer to the midline to make the repair easier. To understand the palate deformity and repair, it's crucial to understand the hard palate. It forms a barrier between the mouth and the nose. And there's two important muscles in the soft palate, namely the tensor veli palatini and the levator veli palatini, that forms a sling around the soft palate. And this soft palate moves like a diaphragm. It is responsible for the production of speech, closure of the posterior pharyngeal wall, so you prevent regurgitation of food and fluid through the nostrils. And in this picture here, on the right-hand side, there's a cleft. The two muscles are inserted into the posterior shelf of the hard palate. So this two muscles, which is very important for the soft palate, is not working. And when you repair the palate, the hard palate and the soft palate, without repositioning or repairing this muscle accurately, the soft palate is not going to work. The other things that the soft palate do are controlling the airflow. It prevents food from entering the back of the nose. With the hard palate, it also assists in speech production, establishes good dental aesthetics and functional occlusion. Palate repair surgery is performed at the age of 9 to 14 months. And in this diagram here, you see a complete cleft palate, both soft and. The repair is done in 3 layers. We have to repair the nasal layer, the muscle layer, which is really important, and the oral layer. Sometimes the length of this palate is short. We have to use different flatten the palate. So in this slide, this child here has a complete cleft palate, cleft of the hard palate and the soft palate. And on the right side, 2 flaps have been raised. The nasal layer is repaired, the muscle layer and the sling reconstituted, and the oral layer has been moved from the side to the midline for closure. This gap here, where the oral tissue has come from, will fill with granulation tissue, and after about 3 or 4 weeks, there's no further defect. Same patient, different patient, just to show you what we do to repair the cleft palate and to lengthen it. Sometimes we use gel foam to fill in the gaps here to help granulation of the raw areas. So all babies are screened, and a further formal hearing test is performed at about 6 months. 95% of babies with a cleft palate will have hearing problems. This is mainly due to a non-functioning soft palate. So the muscles in the soft palate, which is the tensor veli palatini and levator, they insert into the eustachian tube, and the muscles actually helps with the opening and closing of the tube, and this allows ventilation and drainage of fluid from the middle ears. So in cleft palate babies, they would have effusion and they would have a conductive hearing loss. So all babies well, not all, 95% of babies with cleft palate will need ventilation tubes or grommets. So the grommets are performed, the procedure to insert the grommets are performed by the ENT surgeons at the same time as the cleft palate repair. These small grommets can block, they can fall out, and they may need to be replaced. Kids with cleft palate will need grommets till they're about 6 or 7 years old. And in that time, they can go through a couple of sets of grommets. After the insertion of grommets, each grommet, they need a hearing test. After the first 2 years, speech language assessment becomes the next big hurdle. The speech therapist plays an important role during this time. Formal speech assessment is performed at 2 years, 4 years, 10 years, and at 16 years. Velopharyngeal incompetence, which is an important topic for plastic surgeons. About 20% of kids with a cleft palate will develop some form of VPI speech. VPI speech could be minor, moderate, or severe. Minor velopharyngeal incompetent speech can be treated successfully with speech therapy. However, for the moderate and severe ones, these patients will need some sort of lengthening of the soft palate. So this slide here shows a normal functioning soft palate. So the soft palate is working and is touching the back of the posterior pharyngeal wall. On the right side, this patient has significant velopharyngeal incompetence. The soft palate is not touching the posterior pharyngeal wall. So in this patient, there may be regurgitation of food and fluid through the nostril. They will have characteristics, VPI speech, such as glottic stops, pharyngeal fricatives, nasal escape. And in this patient, further surgery is needed to lengthen the soft palate or to augment this area so that when they, so that there is actually contact with the posterior pharyngeal wall. So the next step would be lip revisions. So lip revisions are performed before the kids go to school. We perform lip revision for minor notching or minor asymmetry of the lip repair. And alveolar bone graft is needed in patient with a cleft palate associated with a cleft in the alveolus. The canine tooth bud cannot erupt and grow to the right position without when there's a bone cavity in the alveolus. In this patient, just an example to show you what a bone graft is. We harvest bone graft from the iliac crest, and this gap used to be a cleft in the alveolus, is filled with the bone graft, and two buccal mucosal flaps are raised to seal this area. The canine tooth bud will, when there's bone, it will erupt and grow down. Orthodontics is then involved at the next stage. They realign the teeth and make it into a semicircular arch. In patients who have had significant cleft palate surgery, the maxilla could be narrow and slightly retruded. So in this patient, the orthodontist will use expanders to increase the lateral growth of the maxilla and to reposition the teeth in the right order. When the patients reach skeletal maturity, facial rebalancing surgery is performed. So, for example, in this patient on the right-hand side, you can see the maxilla is underdeveloped or retruded to give a better airway. We also perform a small little ski jump for her nose tip. The next thing I want to talk about is the role of our cleft coordinator. Appointments. So the cleft coordinator is really important to coordinate all the different appointments. Is a point of contact for the patients and the parents. They provide some knowledge, advice, and reassurance. In Australia, we have Cleft Pals, which is a volunteer-based organization that supports families, individuals with cleft, can subscribe and sort of share their experience and their knowledge. Thank you. Any questions?
James, thanks very much for that great talk, a very clear and concise summary of the steps involved. And it's quite a complex journey, isn't it?
Yeah, it's a long process.
Yeah. In terms of you as a surgeon operating on these babies after birth, what are the key things you look for in an antenatal ultrasound report or in a prenatal management where you counsel these patients when you first see them? Because when we make a call of a cleft, we refer to you for a prenatal consultation. What's the sort of key information you look for in a report in guiding you how to counsel the patient?
So is reported to be unilateral or minor, then we'll tell the patients and the family that, look, we can repair and the aesthetic results will be good. If you report that there is a big cleft or bilateral cleft, then we'll show them some photographs and say, look, the deformity is significant. We'll do our best. The appearance will be good. Surgery, bone grafts, and sort of rib grafts or the nose.
Yeah. And in terms of the patients coming through with a diagnosis in ultrasound, what's your experience or take on the diagnosis being upgraded or downgraded in terms of its severity postnatally? Is this a frequent problem you encounter with, or what's the published literature on our sensitivity and specificity of the call we make antenatally on clefts?
At Monash, and there's new signs, the equal sign and things like that.
Yeah. I mean, there's a lot of the various repairs. That's an important part of the repair. I think looking at the newer technologies of 3D reconstruction, and if there's fluid in front of the fetal face, for most there is at the mid-trimester, you can certainly get a much better idea from a visual point of view as what the degree is of vasal flattening. Whether the nostril is absent or present, I mean, Prashant, you may want to comment to that as to how good we are in determining that, because I think then we would need to go into axial views to determine the presence of the absence of a nostril on one side or the nasal cavity on one side.
There are a couple of things which probably you have covered very nicely. And one important section till now, and then we try to see the face like a lip and the nose from outside. Now we have really not tried too much of thing to look in a coronal section, because the coronal section is going to be important in looking at a vomer bone and the two cleft two palatine shelves, which are how they are developing. The moment you get a coronal section, crystal clear idea how far the palatine shelves are, how good the Womert bone is, what exactly the triangle, what exactly the quantum of the defect is, and that is what is going to be very interesting. That's what I'm going to share, how you can really evaluate that region. That region is in a three-dimensional structure. It's not a two-dimensional. So palate, if you evaluate bony structural palate, you will not be able to evaluate the soft palate because it is in a curved nature. So you have to evaluate in a three-dimensional because it is not a flat structure. So we are going to share that. And again, thank you, James, for excellent talk and showing us how a patient with a cleft lip and palate will have to go through the stages till the age of 18 or 20 years. Thank you very much for that.
Thank you very much.
Thanks very much, Prashant. There's also a question coming here from Hamid Sharifa from Malaysia, who's asking a question in general to the speaker in the setting of an isolated cleft lip and cleft palate, particularly when looking at what James has just described as the multiple surgeries and multiple hospital visits with many disciplines involved is part of the repair. And I think I'll pass maybe a comment to that first, is that one of the key things in an antenatal diagnosis of a cleft is while we make the call of a cleft, in a sense, we are not armed with that expertise as to go through to the next step. And that's why, in a sense, it's a multidisciplinary team approach to management of cleft, because a patient needs to understand all aspects before making any decisions. It does vary from one country to the next in terms of management options or pregnancy options going forward. But I think what the key thing is that multidisciplinary team in making a decision as to going forward. And for some patients, I'm sure that may be your experience as well, James, after hearing it all, they actually make a decision not to continue the pregnancy. But as John Rigi mentioned, is that 95% actually make that call to continue. And that certainly would be our experience. I don't know if you want to comment to that.
We have very different experience in India because patient has to pay every step, right from a prenatal diagnosis for genetic testing for next generation sequencing or microarray, then to get the things delivered and all steps till 18, 20 weeks. There is very limited source of government support. There is no NHS like scheme available in India. In majority of the centers, they are all government setups, which may not be having that much of expertise also, or the instrumentation setup. So people here there is more tendency for termination. It's about tendency. I'm saying tendency. Okay, so if you counsel that's how the things are, you send it to the pediatric surgeon who operates, and then there are more chances that they won't go for continuation, especially for the midline and a bilateral cleft lip and a palate with an alveolar ridge prominent.
Sure.
And Prashant, I agree. I mean, there's a lot of things that come into decision making, and certainly economics in those settings where there is no public health system will surely play a part. The reason I was so keen today to have James on, and thank you, James, for really a fantastic overview, is that we are often the first people who will give that information to the parents, that first counseling. And I think it's useful for all of us to be aware of the different elements that are involved there. I was chatting with Tessa earlier, and she was making the point that, that first interaction often is what sets the tone and how parents then, act subsequently. It's quite difficult if you've had a bad first counseling session. It's quite difficult to overcome that. Termination of pregnancies, it's questions coming through. Simon, I think it's going to be an individual choice, isn't it, based on the different interactions and elements that we've talked about, whether it's sort of social aspects, the economic aspects. People have ethical, religious backgrounds that will, like any decision for a termination, I suppose, it's the things that will come into that within the legal framework of each setting. So, certainly in the UK, for instance, it is legal to have a termination of pregnancy up to 24 weeks of gestation. It is possible to have termination for lethal abnormalities, or extremely severe abnormalities, even beyond that, under which this would not qualify. But obviously that's different from setting to setting and from in different individual countries.
Before we move on, sorry, James, go ahead.
Yeah, so I've worked at Monash for about 20 years, and we see about 30 cleft patients a year. And I've had one patient that came to antenatal counseling and then decided to terminate. So that's out of 600 patients, or well, maybe 400. Only one decided to terminate after the antenatal counseling. So it's pretty rare.
Thanks, James. Just before James started to ask the question, and Gianluigi, this is for you, and as well as Tessa, is when you see an underbite on an antenatal scan, let's say at 20 weeks of gestation, do you set about trying to distinguish between retronathia, and does that carry any genetics implication, trying to distinguish between the two?
Luigi, do you want to go first?
Whoever, and maybe Gianluigi and then genetics, because that's the order it would happen.
I am more interested in your comment, Tessa, about whether there is a difference in that. I would say it is quite difficult for us to assess whether it is retronathia or micronathia. In general, retronathia is not too severe micronathia. If you have a big overbite and you see very small bone, that is usually true micronathia. But is there a difference? I guess there is.
I think the only thing that worries me is, have we in fact got a muscle problem rather than a physical problem? Have we got some form of occult arterogryposis, and they've got some primary muscle abnormality, and that's what worries me with the retronathias. Actually, we're not dealing with a primary problem of the chin; we are dealing with a neuromuscular abnormality. So that's the only subtlety as far as I am concerned. And I would be asking my ultrasound colleagues to really look for evidence of arterogryposis. So that's what I'm looking for, rather than the sort of physical side from a treatment point of view.
Yeah. So, Gianluigi, in summary, from an antenatal point of view, you see them.
I would say it's very difficult.
Yeah.
And when you have a positive diagnosis of a significant chin that is dislocated posteriorly, that is usually micronathia. I don't remember ever being one single case that we diagnosed with that condition that turned out to have a retronathia isolated. All this was micronathia.
Yeah. And just lastly, for both James and for you, Gianluigi, in terms of premaxillary protrusion, we are aware of seeing this in the bilateral cleft, which you showed very nicely. But is premaxillary protrusion something we also see with a unilateral cleft? Or do you feel that's just solely an entity in bilateral?
The premaxillar protrusion is mainly in bilateral cleft lip. In unilateral, you can have one side of the arch kind of like sitting forward, and the other side of the alveolus sitting behind, but there's really no protrusion as such.
Yeah, so alveolar collapse you see on the abnormal side, but you don't see protrusion.
Yes, that is the point. If you see protrusion, like the one that I showed, it is always bilateral. Then if you have a big unilateral, as it has been discussed, you may have disarray, one higher than the other one, so on. It's difficult to tell. But the protrusion, the thing that looks like a mass, is always bilateral.
Okay, thank you very much.
I think it's relevant for people who do ultrasound, because sometimes it's not so easy to see the defects into the palate. So you may wonder, is it bilateral, is it unilateral? But if there is protrusion, even if you don't clearly see the gap, it is always bilateral.
Okay, thank you very much. James, it's the late hour. It's heading towards one. Feel free. You don't have to stay to the bitter end. But seriously, James, thank you so much. It's fantastic to get your perspective on it, which is, I've learned so much from it. Thank you very much.
Brilliant, James. Really, really, really great. Simon, can I ask you a question? Because this is a bit relevant to your setting. We have the nice thing of this webinar is there's so many people, and this is a question from someone in Botswana who's a sonographer. And I guess this is a common question for places where you have a sonographer doing the scan and then a physician reporting. And the question is, look, I've seen this, and I know this is a cleft lip and palate. How comfortable would you be as a physician, as a reporting physician, for me as a sonographer to give that initial information to the parents? What's the dynamic there? What do we do? Because it's difficult for us sonographers just to pretend that we haven't seen anything when actually, we can clearly see that there is a problem. How do you deal with that in your practice, Simon? Because I guess this would be the same for any abnormality in some sense.
True. I mean, I guess any abnormality where it has a risk of a false or a positive or false negative diagnosis, you have to restrain until you have certain information. So the question is really, what's the certainty of diagnosis with a facial cleft? And I think there are false positive situations with the umbilical cord in front of the face, a prominent philtrum, that can lead to false positive diagnosis, the more subtle clefts. For the very obvious clefts, I still think it really falls into the realm of the medical practitioner, because as Tessa said, it's so critical how you relay your first piece of information to that patient that I think you have to not just focus on the lip, you then have to go for the rest of the face, see if there's any associated facial abnormality in any of the markers. So for a sonographer to give initial information, I guess it depends on the setting that they're working in and what support they have. But if they have the support of a subspecialist who counsels the patient, I think it would be more appropriate that the primary specialist does the initial consultation. If they're working in a rural environment where remote transfer of images down the wire, which happens in Australia, then you may be left with what you do with what you can, the situation as best you can in the situation you're faced with, because the patient can't sit waiting for hours in an airport before they fly out to get an ultrasound, and they want to know why. But even that scenario now in Australia, we have down the wire, we can look at images, but that in itself, you're looking at somebody else scanning. Yeah.
Thank you so much, Simon. That's really helpful. I think we better carry on, Simon, if that's okay.
Yeah, I think so. So do you have my screen just to bring up? Have you got my screen there, Iris?
No, you have to share your screen.
Okay, so if I can just share mine and okay, you got me now?
Yeah.
Okay.
We got it now.
Great. So it's my great pleasure to introduce our next speaker, Waldo Sepulveda from Chile. Waldo is an obstetrician and gynecologist and subspecialist in maternal-fetal medicine. He's the current director of Maternal-Fetal Medicine Diagnostic Center in Santiago, and has been a long-standing member of ISUOG and the American Institute, and is in fact a fellow of both of those societies. His training was across 3 prestigious centers in Yale, publications to his name. So he has an outstanding academic career, but more important of all, Waldo is a great friend of mine who's been very supportive to our courses and papers we've written together over the years. And it's a great pleasure when he accepted to present, because Waldo has published on many signs relating to the fetal face and also in the first trimester. So Waldo, I'll hand over to you, and thanks very much for joining us this evening.
Thank you very much, Simon, for the nice introduction. Thank you, Aris, for the invitation. And I'm very happy to be here because this is a quite a hot topic in prenatal ultrasound. I'm quite sure that actually if you miss a cardiac defect, the patient will forgive you. But actually, if you miss a cleft lip and palate, probably you will not, and you will get sued about this. That's why, it's very important to check for the baby's face. If you look back several years ago, actually the examination of the fetal face was not even considered in the routine scan. And after the institutional guidelines started to promote examination of the fetal face, we started to diagnose cleft lip and palate. I'm going to share the screen. Okay, I think you have it on yours.
Yes.
Okay,
Yeah.
Yes, we've got it, Walter.
Excellent. Okay, today I was asked to speak about what we can achieve in the first semester. And here is very important to mention that actually, during the second and third trimester, is relatively easy to diagnose the cleft lip and palate if you are lucky. If the baby is in a good position with good amount of amniotic fluid, and if you don't have the umbilical cord in front of the face, and if you don't have the arms or the legs in front of the mouth. But actually you can manage with this because actually you have 20 or 30 minutes just to scan the baby and to go back to the fetal face and try to document that actually the upper lip is intact. But if we look in the first trimester, it could be even more difficult. If we look at the information from King's College Hospital, dealing with almost 50,000 cases with no chromosomal abnormalities, you can see that this paper that was published 10 years ago, they were able to diagnose a facial cleft in only 5% of the cases. And they were not specific about if these cases were in the setting of multiple abnormalities or isolated. It's not quite clear in that paper. But actually, you can see that you are missing 19/20 of this cleft lip and palate. This is quite important because actually this was not considered at that time a target for the detection of orofacial clefting. This is the last review of the same institution at King's. You can see that was published 1 year ago. And here they gave the information about, the different types of orofacial clefting. And you can see here that actually that 5% increased to 35%. That means that there was an improvement, probably because they were looking more closely at the fetal face as part of the routine first trimester anatomy scan. And this is quite important data because actually you can see that the number of cases here were 100,000 patients with no chromosomal abnormalities. That means we are improving little by little. It's very important that when you have a cleft lip only, there is no cases diagnosed in the first trimester. The 24 cases were diagnosed in the second trimester. And when there was cleft palate only, all of the cases were diagnosed postnatally. This is a big challenge at the moment, just to be sure to check the palate in the fetus, either the first, second, or third trimester. And here we go about the fetal face. It's very important to mention that actually for all the time we have been looking at the fetal face, but actually it's not difficult to see the nose, to see the mouth, to see the chin. You can see here transvaginal ultrasound, very detailed images. And also with the help of 3D ultrasound, also it's very, very amazing how you can get very nice images of this area of the face, the mid-face. Now we're using a very detailed ultrasound scanning, including 3D ultrasound in some cases. And you can see that you can rotate the fetus. You can also use the Magic Cat to enhance the visualization of the fetal profile. You can see even details that they are not possible to get with 2D ultrasound, for example, to see the ear. to see the eyes, to see, part of the mid face. And this is increasingly used for the anatomical evaluation of these fetuses. But what happened with the examination of the fetal face in the first semester? There are two main limitations. One is the size and the other is the technique. The size of the fetal face from the tip of the nose to the chin in this baby with 13 weeks, you can see that it's about 12 millimeters. If you look at your hand and you see the tip of your finger, this is my finger, you can see here that 12 millimeters is really a little bit more than half of your finger. That means you are examining a structure that is really tiny. And actually you need very good equipment to magnify the image and to get good resolution to see the different structures. Therefore, you need to have good technique and good equipment to examine the fetal face at this gestational age. What's about the technique? We know that we had put a lot of efforts in the evaluation of the fetal profile during the nuchal translucency scan. However, the detection of malformation of the face is still a diagnostic challenge. And one of the main problems is that we learned how to scan the first trimester fetus in the sagittal view. And all of the information from the Fetal Medicine Foundation encourages to check the fetal profile in a very high detail, looking for the nuchal translucency and looking for the nasal bone. And this was very important because the first time that we start checking for the fetal face was for the diagnosis or the detection of trisomy 21. But actually, now we know that it's very effective, but for the detection of cleft lip and palate is not very good. And why was that? Well, about 10 years ago, I checked the literature about what's going on with the diagnosis of cleft lip and palate in the first trimester, and just find out two papers. Two papers were from Italy. You can see here, the first one was in 2006, was quite a prominent orofacial clefting. You can see here the baby, they used transvaginal ultrasound. The diagnosis was made at 11 weeks. And another group from Italy as well, you can see in 2009, they just did a 3D ultrasound and they found that this bilateral cleft was also diagnosed by 2D ultrasound, but also with the help of 3D ultrasound. That's been up to 2009, there was just few authors reporting the prenatal diagnosis of cleft lip and palate in the first trimester. And what was the main problem? The main problem was that actually, when you are looking at the fetal sagittal view of the face, you can see here that you only see a small piece of the upper lip, mainly in the center. What happened? You need to turn the baby just to look at the baby from the coronal view, because here you can see in green that actually the main bone involved in the formation, in the development of the midface is the maxilla. And you can see here that you see the alveolar ridge here and two projections to the top, and these were crowned by the nasal bones. And here, this size, you can see that the shape is the shape of the triangle. This is very important because actually when you are looking this part, you are able to see in this view a coronal view of the alveolar ridge. And we know that in fetuses with orofacial clefting, about 80%, 75% of the cases, there is involvement of the alveolar ridge. That's mean with the simple view of the alveolar ridge, you can make a screening test to detect fetuses with orofacial cleft in the first trimester. Another point of importance here is that several years ago, this area was called the zygomatic bone, but actually the zygoma is really the malar bone that is outside the midline and not involved in the area of the triangle over here. Okay, but in any way, when you have a baby in this position, in the sagittal view, you are also able to see several other structures. We are focusing in the nuchal translucency and in the nasal bone, but actually there are so many other structures that you need to be aware that they are there, and you need to learn how to read it very quickly when you're doing the scan. For example, you can see here part of the frontal bone, part of the soft tissue in front of the frontal bone. You see the skin, the tip of the nose, and also you can see very nicely the upper lip. You can see the difference between the primary palate, the soft lip, and the amniotic fluid. And you can see that it's very smooth over here. You can see a very nice line with good contrast with the amniotic fluid. You see the lower lip, the chin, and the mandibular bone over here. And also when you are looking in the mid-sagittal plane, you will see that actually here there is an echogenic structure that is the palate. And here in the first part, in the anterior part, you see the primary palate. And here you can see the secondary palate. That's quite prominent, and it's very important to get this view, but because at this gestational age, the palate is almost flat. And if it's almost flat, you can see it in one single plane. And we also need to remember that actually when you have a cleft palate, the cleft palate only affects the midline. That means if you get a good midline in this fetus and you see the primary palate and you see the complete secondary palate over here, you can rule out very easily that there is a defect in a baby's palate. Also, there is a separation here. You can see that there is another echogenic structure in top of the palate here, that is the Bormian bone. Here you can see that actually you can take advantage of this view that actually is the one that we are using for the screening of trisomy 21. And you can see a lot of things at the time you are just checking this information. And also you should add these other structures into your list of structure that you need to check out. And also, if you just rotate the face and you see this baby in the frontal view, in the coronal view, you also will get some other information about the metopic suture, the two frontal bones, the orbits, the lens, and also this midline structure that is the most prominent one in this view. That you can see that the bone here from the maxilla are quite clearly displayed. And you see here the alveolar ridge. That means that you can see that the alveolar ridge is intact. That means that the possibility of an orofacial cleft is very low. And actually, with this view, you can rule out almost an anterior cleft, but actually it's not possible to rule out a cleft palate. Also, you can see the mouth and the two bones over here that actually is the posterior part of the mandibular bone. In the middle, you should see also a gap that we call the mandibular gap, because actually when you have retrognathia, you will see that this is going to disappear because this area, you can see it absolutely solid or even absent in these cases. The mandibular gap is about 2 to 4 millimeters. That means that it can be easily observed at this gestational age. Also, it's very important, this view, because you can see the nasal bone. That means that if you don't get the nasal bone in the sagittal plane, because the baby is in an unfavorite position, you can use this view to check that the nasal bones are also present. That means that there are multiple tasks that you can use this view for your screening in the first semester. We came out with this idea of checking the coronal plane, and we published the first paper early in 2010, the retronasal triangle. We call it in this way because of the triangle that is formed by the maxillary bone crowned by the nasal bones. And we start checking this information. And this was the first paper that actually did a very comprehensive examination of the fetal face in the first semester. This was done with the help of the group in Madrid by Pilar Martinez, that you can see here that actually using 3D ultrasound together with 2D ultrasound, you can see several other structures, and you can navigate in the fetal palate, you can navigate in the mouth of the baby, and you can get several information. The retronasal triangle is just the anterior part, but using the same technology, you can also navigate deep into the fetal palate and to check for cleft palate as well. You can see here that using 3D ultrasound is very easy to see the sagittal view and the difference in relation to the examination of the alveolar bridge using exactly the same view, but in the coronal plate. This is the orthogonal plate. You can see here the reference dot over there, and you can see that actually, it's very easy to see this base of the triangle that demonstrate that actually the alveolar bridge is intact. If you just start looking at fetuses with a cleft lip and palate, you will see that you have two views that can use for the diagnosis. One is the coronal view using the retronasal triangle, and the other one is the sagittal view. And you can see here that there is a big gap in the palate. Note that this is quite a central lesion. That means that you can check it very easily at this gestational age. And here we have two fetuses with holoprosencephaly that actually that there is a high association with facial abnormalities. And you can see here this baby, that when you see the coronal view, here is part of the triangle, but actually you can see a gap here in the base of the triangle. And here we did the diagnosis that actually this fetus got bilateral cleft lip and palate. Also another case that you can see that there is something wrong around here. There is a maxillary gap as well here. You can see the two nasal bones in this fetus, but actually there is a parallelism of the bone over there, and there is no palate as well. And this is a picture of this baby, and the chromosomal analysis revealed that the baby got triploidy. That means that this is quite a very important view, because you can compare here the sagittal view with the coronal view, and for the alveolar ridge or primary palate, you can see that it's very easy to detect this sort of malformations over here. How do you do it? Now it's very easy to do it, because actually if you have a good equipment and with good resolution, you just magnify the area of the face. You can see here this baby is at 12 weeks of gestation. And you just move your transducer from the head down into the face. And here you can see all of the structures. You can see the nasal bone in the top. You can see the retronasal triangle. And you can see here the primary palate or alveolar bridge. Down there, you can see the mandibular bones. You see the mouth and the mandibular gap over here. This is quite important view that you should include in your routine scan. It's not difficult to do. Actually, it's very easy if you get a good transducer and you start checking this, and you're going to do it very easily in your case once you learn the technique. Even more, if you look at this view, also it's very important to check for the hands. You can see here that you can see very easily that the hands are present. And also you can see there in the upper portion over here that actually the retronasal triangle is present and intact. If you have a doubt, you need to go into 3D ultrasound. In the first trimester, it's very easy because, as I mentioned before, the palate is very flat. That means that you can get the three-dimensional view. You use the orthogonal planes over here. You can see here that the nasal bone is there, the palate is here, and the chin is over here. What you need to do, and this technique was described by Pilar Martinez, that actually is very clever, because you can see that once you have this information, you just need to put the reference dot in the primary palette, and you put here the palette in perpendicular view. You just turn this baby, and you can see here that when you do this this turning, you see the retronasal triangle, and at the same time you are looking at the palate over here, and there is no gap in the palate. That means with this simple technique, if the baby is in a good position and you get a good volume acquisition, you will get this information in a couple of seconds. That's why it's very important that when you have a doubt about cleft lip and palate, you need to move on 3D ultrasound for this reason. Let me show some of the cases that we have been dealing with. This is a fetus at 13 weeks. You can see here that the baby got an abnormal face. Immediately you can see that there is something wrong in the upper lip, and you can see that there is a premaxillary protrusion here. You can see the nasal bone present. The baby had, you can see a megacystis there. And when you look at the coronal view, 13 weeks, you see here the tip of the nose, the two nasal bones over there. You see the lateral aspect of the maxillary bone over there, and you see a bilateral cleft. You can see here, this is the still image. Here there is one gap, and here there is another one, and there is no base of the alveolar ridge over here. That means this baby got a protrusion over there, and also got a bilateral cleft lip and also palate. This is another case, it's very similar to the other one. This baby got a microcephaly and also got here an abnormal face. The profile is absolutely abnormal. You see here the premaxillary protrusion. Immediately you know that this baby had a bilateral cleft lip and palate. And also here you can see that the posterior part of the palate is intact, but there is a gap in between the primary and the secondary palate over there that is called the maxillary gap, that was described by Ravi Chawi a couple of years ago. And also this baby, because you know all of the mid face and the lower face is affected, most of these fetuses may have also an associated micrognathia. Another case at 12 weeks, you can see here that when you are looking at the sagittal view, you see that the baby got increased nuchal translucency. The nasal bone is there, but actually there is a distortion of the mid face over here, suggesting that the baby had a cleft lip and palate. Of course, this baby should go to prenatal karyotyping, and the first thing that you need to rule out is a trisomy 18 or trisomy 13. This is the same fetus, and you can see that there is increased nuchal translucency over here, and you can try to make a triangle over here, and you don't see it. You can see here part of the maxillary bones over there. Let me a little bit. Here you can see the maxillary bone is intact. However, if you look at the upper part of in the upper lip, you see part of the maxilla over there, but you don't see a normal area of the alveolar ridge or primary palate. This is another case. You can see that also, you know, most of these baby are going to show some sort of problems here. There is a clear maxillary gap over there. The lip looks quite fine, increased nuchal translucency. But actually, you know, when you look at the 3D, at the transvaginal scan, you see here that there is a bilateral cleft lip in this baby with multiple other malformations. Here, there is a baby that actually you can see here that you need to learn how to look at the palate in these babies. You can see that there is a missing, almost missing palate in this view. If you move a little bit to the left, you can see a maxillary gap over here. Nasal bones are present, but actually this baby, if you look at transvaginal scan, you will see that actually, the lip is not normal. And you can see here that there is a unilateral cleft lip in this baby over here. This was an isolated one after 10 weeks. If you look in the coronal view, you will see that the retronasal triangle is not normal. You see the nasal bone in the top, and you can see here that there is a unilateral cleft lip in this fetus over there. But when you look at the axial plane, you will see that actually there is also some abnormality in the palate. You can see here the gap. This means that there was a unilateral cleft lip and palate in this fetus. This was diagnosed at 13 weeks. Let me show you another case. This baby was referred because they found something abnormal in the fetal phase. We also find out that there was a problem in the posterior fossa over here, increased nuchal translucency. And when you look at the views, you will see that there is an abnormal upper lip over here, and this baby had a bilateral cleft lip and palate. This is the 3D ultrasound in this fetus. You can see that it's very easily to see that there is an abnormal upper lip. There is a bilateral cleft. You can see here maxillary protrusion. And here you can see that the nose is distorted because of this area. You can see here that this baby had a normal karyotype. We didn't have the chance to do any other genetic analysis. And here is the picture of the baby after the baby aborted. Over here, you see the big distortion of this area, and how you can see in this baby the maxillary protrusion as well. This is our experience, just to trying to put this in the context of a fetal medicine center. This is the information that we have in the last 5 years. Actually, this is not a common reason for referral, but actually you can see that most of the cases that we are checking for cleft lip and palate are really not isolated. Most of these cases are coming from the population of trisomy 13 fetuses. And this is, you can see here, at least there are 3 of these fetus had trisomy 13. Most of these babies with trisomy 13 have the holoprosencephaly spectrum, some others not. And also we have a case of trisomy 18. And you can see here that actually in one case, we missed the diagnosis in an isolated unilateral cleft lip. And here, this case was diagnosed at 20 weeks. All of the other ones were normal, and one case didn't have a chromosomal analysis, and the baby didn't have any other associated abnormality, but an increased nuchal translucency. You can see here that actually, when you're running a fetal medicine unit, probably you will see more cases referred because of additional abnormalities in which you find out that the baby got an associated cleft lip as part of the multiple malformation syndrome. Also, it's very important to learn from cases. This patient was referred at 20 weeks. You can see here that there is a quite prominent maxillary protrusion. Let me tell you that actually you diagnosed maxillary protrusion when the tip of the lip actually is anterior to the tip of the nose over here. You can see that it's very easy to see. All of the primary palate is protruded into the protrusion over there. This is the view showing that there was a bilateral cleft. You see one here and you see another one here. This was an asymmetrical cleft lip and palate. This is a picture of the baby showing the 2 clefts. And actually we managed to get this information from the referring center, because actually it's very important to learn from our mistakes. And you can see here that the fetal phase was normal. The doctor who did the scan got a very nice view of the nuchal translucency and the nasal bone. This is quite a mid-sagittal plane, a very good view. You see all of the posterior fossa as well. But actually, if you don't know how to look for cleft lip and palate, you probably will miss this case as the doctor who performed the scan did. Here, there is a premaxillary protrusion. You can see that the tip of the lip is just anterior to the tip of the nose. And also you see here the gap. Therefore, you need to look in all of the fetuses. That's our recommendation. You need to look for the upper lip over here. And also you need to look for the maxillary gap in this view. How do you check for the fetal palate? This is a paper that we published several years ago with several institutions. We were collecting cases. You can see that was almost 10 years ago. And actually, you know, we took advantage of 3D ultrasound, and also we took advantage of the fact that the palate is almost flat at this gestational age, and there is no artifacts from the presence of the bones, because actually there is no shadowing at this gestational age as it happened in the second and third trimester. You can see here that it's very easy to get with this oblique view, the view of the retronasal triangle. You can get multiple views of the fetal primary and secondary palate. And also with this simple technique in which you draw a line over here and you have the split screen over here, you can see that this bone is clearly seen that in the midline there is no gap. That means there is no cleft lip and palate. That could be very important if you have the chance to check, or if you have the doubt if this baby had a cleft lip and palate. What happened here is that you can make the diagnosis of a cleft palate, isolated cleft palate, just looking at this view. But if you have a doubt, or if you have a baby with a cleft lip, you can also add this information to get information on the palate in the first trimester. How it performs, you know, let me show you a paper that we published several years ago with a group in Madrid. You can see here that actually is very important using the technique described by Pilar Martinez, that using this technique in some volumes, 3D volumes, is very easy to see. Also, there are some cases that actually could be false positive that you need to be aware of. For example, you can see here the primary palate. We diagnosed 9 cases of cleft, but actually there were only 7. That means that there were 2 false positive cases. But actually, when you see an intact palate, the specificity of this technique is quite good, because all of the baby with intact palate had an absolutely normal cleft lip and palate. These were the pictures that you can find out in the publication. These are the 3-dimensional multiplanar views. And also here you can see the 3D ultrasound. Among these fetuses, 3 had trisomy 13, and there was only 1 case of an isolated unilateral cleft lip, in this case, that is number 4 over here in the list. Also, it's very important that every time that you get a cleft lip and palate, you should check for the fetal hands. Dr. Humphrey already mentioned the EEC syndrome, because you can see here that there is a prominent cleft lip and palate in this baby, and the baby also got ectrodactyly. And this is a genetic condition that actually you need to be aware of. That means that it's very important to check for the hands every time that you diagnosed a cleft lip and palate, either in the first, second, or third trimester. And just to finish, you know, do we need to screen for cleft lip and palate in the first trimester? Let's check here a paper with over 5,000 women. This is from China. They were checking the retronasal triangle in the screening for trisomy 21. They included the visualization of the retronasal triangle. And you can see that actually they follow a very strict protocol, that every time that they have some doubt, they use 3D ultrasound in abnormal or suspected cases. They were able to get very good images in almost all the cases. And they were able to diagnose 7 out of the 8 cases of cleft lip and palate at this gestational age. sensitivity was 87%, and the specificity almost 100% of the cases. Also, remind you that actually, if you're not good for checking the nasal bone, you can use this plane. And when you are checking for the nasal bone in the coronal view, also you can check for the primary palate over here. This was a paper published also with the Madrid group. And you can see here that actually it's quite easy to see unilateral absence or bilateral hypoplastic nasal bone and absent nasal bone in this plane over here. Some words about micrognathia. This is a fetus with trisomy 18. You can see that actually the nuchal translucency was not so prominent. Also, you can see a very nicely demonstrated nasal bone over here, but actually the chin is really in the posterior part of the face over here. And you can see that the upper lip is normal, and this baby got micrognathia. Just remind you that actually the first paper on the first trimester diagnosis of micrognathia was made by the group of Simon Meg. And you can see here, these were the images that actually they are quite good, because just looking at the fetal face, you can see that there is a receding chin over here, and this baby had a Pierre-Robin sequence over here. And this lady had confirmation of the diagnosis at 19 weeks and proceed with termination of the pregnancy. I have some doubts about, these views over here. This is a baby with micrognathia. Also, we need to be aware that actually, if you have micrognathia, you need to think in a condition that is called triploidy. This is a baby with triploidy. You can see here big head, small abdomen, and when you see here the retronasal triangle, you can see here the triangle, and also you don't see the mandibular gap. And this is the baby with 3D ultrasound. This is the karyotype. And also, we need to check for the retronasal triangle as to check for micrognathia as well. And what's the reason for this? Because, if you draw a line between the nasal bone and the primary palate over here, you will always have this line crossing behind the chin in normal fetuses. But if you have micrognathia, you can see that actually this line from the nasal bone to the primary palate, you can see that this is behind the line. That means when you look at the coronal plane, you will see a solid bone or even not bone at all. Here, for example, this is a normal baby with a mandibular gap over here, and this is a baby with a triploidy, where you see here the alveolar ridge, the primary palate, but you can see a very solid mandibular bone with no mandibular gap at all. This means that this baby got micrognathia over here. This is a picture with Chawi, with Ravi, that actually we met in the meeting talking about this point. And just to finish, another even more easy way to find out about micrognathia, rather than to draw the line between the nasal bone and the primary palate, just draw the line between the anterior part of the mandible to the primary palate, and you look at this space over here. If you have a normal baby, normally this gap over here is very small, almost this line will touch the frontal bone over here, but if you have micrognathia, you will have a huge frontal space distance over here. This was described by the group from Cathy Bilardo in the Netherlands, and actually it's quite easy to see in the same plane that you're doing your stuff over here. However, if you look at this case over here, that actually is the same fetus. This is at some position that you can see that the space over here, the frontal space, is not very prominent. But actually, if you look a little bit later, you can see that you can make mistake using this. That's why you need to check very carefully about this sign, and you need to combine the signs just to do diagnosis of micrognathia, because this is a very difficult condition. And also you need to be very sure that the baby got the problem, just to get appropriate counseling to the parents. And just to finish, this is a paper that actually we published with a group in Colombia, Dr. Rodriguez and Casas Buenas, where they didn't found, you can see here, the mandible. The baby got palate, but not mandible over here. This is the retronasal triangle, and you can see that there is nothing underneath over there. And this is the picture at 12 weeks, and there is no mandible in this fetus. This fetus got a condition that's called autocephaly. As you can see here, there is agnathia, cyanotia, melotia, and microstomia. And this baby died because of polyhydramnios and premature delivery over here. Please remember that when you have these cases, there is an association, a clear association also with holoprosencephaly. This is where a picture from Dr. Andreeva. And we put here 4 cases and review the literature about the first trimester diagnosis of autocephaly in these cases. Are really rare cases, but actually you need to be aware that actually that can happen. Thank you very much for your attention.
Waldo, thank you so much. What a treat to have the person who first described the ultrasound features to give the lecture directly. And I think this was really helpful for us all to learn about the power of what the first trimester can tell us. Waldo, it's very clear to me that the retronasal triangle is useful. You showed some data suggesting a very low false positive rate. Do you think that if this is rolled out more generally as a screening test, the false positive rate will be as low as that?
Well, what happened, Aris, is that actually you need to deal with gestational age as well. Because if you're checking the retronasal triangle at 11 weeks, you may have false positive information. But actually, if you're looking at a baby at 13 weeks, actually, you can get some sort of ossification of the bones, and you can make more easy to check for this primary palate. That's why, I have the recommendation that actually, if you need to do a good ultrasound anatomic scan in the first trimester, you need to move into the 13 weeks rather than to 11 weeks, because actually there are so many, details that actually you can miss early in pregnancy that actually, just orofacial cleft is just one of them.
And then on the other side, the chances of a false negative, and Else de Jong asks, if you've looked at the palate and you've seen it in the sagittal plane, the vomer and the secondary palate are clearly seen and not interrupted, can you exclude?
I think you can do it because actually, as I mentioned during the talk, that actually is a flat structures, because you will see in the second trimester that it's like a dome. But actually in the first trimester it's flat. That means that it's a very good screening test for cleft palate, isolated cleft palate. And also if you look every time, this area, you will see that actually if there is a cleft lip, also you can check for the maxillary gap. That actually is a very good sign. And the maxillary gap should be present in between the primary and the secondary palate. That means it's a little bit anterior.
Thank you.
Can I ask, this is a question probably for both Waldo and for Gianluigi, is there are so many angles and distances with respect to the face and including the jaw index. If we can start with micronathia, do you have a preference in terms of the many people attending the lecture today as to what is the most, as the sign of greatest yield for micronathia, if we start with that, considering all the jaw index, the prefrontal space distance, the inferior facial angle, and many more? Do you have a preference for one that stands out amongst these in first and second trimester? Maybe if we start with the second trimester with Gianluigi and then move to the first trimester for Waldo, addressing micronathia, retronathia.
Well, as I said before, honestly, there are so many parameters that have been described. And the shortcoming of all these parameters is that whenever you're measuring small things, you have a lot of error and you have a wide prediction interval. And so the ability of that parameter to predict abnormality would be very limited. And in general, I don't like angles, because when we draw angles on the ultrasound images, usually we can make everything. We can make angles of 90 degrees or 120 degrees. The angle is the single biometric parameter that is less reproducible. I honestly believe that micrognathia, when you have a suspicion, should be referred to someone who has an experience, and then it is mostly a subjective diagnosis. I think that the rule of the tango is very good, but there is something that I would like to point out, and it is that albeit I am very keen on ultrasound, we have seen that magnetic resonance is very helpful in making diagnosis when you have problems. It's very effective in identifying the cleft of the palate. Is also very effective in studying the mandibles. We have tried that and it works very well. So I think that this is something that you need to consider as well. When you are in a blind end and you can make the diagnosis, magnetic resonance can be quite more objective than ultrasound. I don't know what is your experience, but there are several papers and our experience has been very good with that. Waldo?
Well, actually, when I check this, I think when you're doing a screening, you need to make things easier. And if you just put angles or measurements or different techniques, actually you are making this a little bit harder for the operator. If we are looking at the screening in the first semester, actually we are used to check the fetal profile in so many normal fetuses that actually you get used to the view of the fetal profile. Therefore, if you have micrognathia, probably you don't need to make an angle when you see that something is wrong. That means that if you see that the mandible is very small, or if there is a receding chin, you just know that the baby got something abnormal, and then you can proceed with the other measurements. So probably you can get a very good 3D ultrasound and work in the multiplanar planes, and just to make any measurement that you want. But actually, the first approach should be just the visual aspect of the fetal profile. In the second trimester, I think it's a little bit more difficult because actually, generally it's in a flected position, and actually the chin is just against the thoracic wall over there. And probably it's more difficult to see this abnormality unless there is an associated polyhydramnios because the baby is not swallowing amniotic fluid well or something like that. But actually, in the first trimester, you don't have the problem with deflected fetuses. And also, just looking at the profile, you will see that something is wrong.
If I can add something, if I can add one thing that is possible, I think that Waldo is making a good point because there is no biological variability in the fetal face in the first trimester. They are all the same. The appearance is so identical in every fetus that you examine that you make yourself a mental image and variation, you get that immediately. Even for the second trimester, it's more or less the same. Fetuses do look very similar in the profile, but less than in the first trimester. So I think, my point of view is for micrognathia. If there is micrognathia, you will see it. You may have doubts, but you will get it. And if it is so subtle that you cannot make a decision, usually it is not. But I think that what we are interested in seeing very, very small chin, not the minor varieties. That is impossible.
I think the one other application about taking a measurement, which I think has merit, is I think there are two groups of micrognathia, retrognathia, whichever you want to call them, is the group that's severe, that are straightforward diagnoses, that are typically associated with 18, 13 and genetic syndromes. There's a separate group who are mild micrognathia, And I think these are a challenging group, particularly in the first trimester, because there's a very significant cohort who have got mild micronasia in the first trimester that is normal by the second trimester. And for that group, I have reservations about entering any discussions about invasive genetic testing. Then there's the group in the mid-trimester, which are less frequent, who have got mild micronasia. And you're left sitting on a chair, making a decision, because you see in one moment of the position of a change of a head, it looks normal, and another looks like micronasia, and you're left in a gray zone. Ultimately, you make a decision which way you're going to go, making a call whether it's abnormal or normal. And in doing so, I think biometry has a role to play in terms of learning from what you've seen afterwards, a role to play in terms of protecting you medical legally, that you've documented the angles and they fall within the normal limit, and therefore you report it as normal. And if the baby was delivered afterwards, you say, well, look, I took all these measurements and angles. And I think in that scenario, I think biometry, maybe there is some merit. But otherwise, I agree with you wholeheartedly. I mean, I think there's, particularly with regard to angles, it all depends where you place your caliper at the end of the palate as to what angle you're going to get. And for a lot of it is subjective. But the problem with all these subjective measurements is it relies on experience. And for the person starting out in the first day with an ultrasound probe in their hand, they want something to measure. But I think it's a good thing to do these measurements, to do 10 of them, 20 of them, and then after that, you learn from taking them. But ultimately, it boils down to subjective assessment. Iris, I think it's bedtime here in Australia. Prashant, you'll have to forgive me. I'm going to keep moving. Thanks very much, Wilder, for your presentation.
My pleasure.
The feedback has been absolutely fantastic on your talk. Many comments coming through on details of your images, spectacular images, crystal clear presentation. So there's been a great appreciation around the globe for your talk today. And similarly, Gianluigi, nice to see you again, and thanks very much. Prashant, we'll be in touch. Cheerio, eyes.
Thanks, Simon, for staying so late. It's very, very late in Melbourne. But we're really looking forward now to hear from Prashant and how he uses in his hands 3D. And what I challenged Prashant to do today is to say, Prashant, I know you can make the most fantastic images in 3D, but don't show me all your images. Teach us how to do it. So that's what he's going to try and do today. Tell us how to use 3D to its maximum in order to help with this diagnosis. Thank you, Prashant.
Thank you, Aris. Again, to all friends, greetings from Scan Academy and also greetings from India. I'm Prashant Acharya. Will take you through the journey of what is the role of 3D imaging in lip and palate evaluation, especially with the cleft lip and palate, what you are dealing with. Now, Aris has told me specifically few things, and now that those things are only possible because of the technology update, which we are all going through in ultrasound technology. It has taken quite a long leap there, and that's the reason. Now, what 2D imaging is, if that's what you are doing always. So if you do what you always did, you are going to get what always you got. But if you are looking at these kind of structures as the 3D images or the uvula or that sort of thing, to get what you never had, you must do something which you never did. And that's what I will ask you to do, which probably you may not have done till now, to use your 3D ultrasound probe to an extent a level high up. To understand the real cleft lip and palate, you need to have a crystal clear anatomy and embryological knowledge. Basically, as you know, that the palate is going to be fused like this, and eventually you will have a soft palate which is going to be developed, and you will have a uvula developed like this. And for that development, there are quite a few things you need to understand. That initially you have got palatine shelf like this, you have got tongue protruding into the nasal cavity. Palatal shelf comes near contact, and then they are going to touch to each other to form the palate. But that you understand that point. But I want you to understand one more point. It's a development of a nasal septum. That's a vomer bone, and that actually touches to the extent which is coming to the base of the palate. So palate is region where you have got a one transverse lip with a left and right palatal shelf, but there is a nasal septum with a vomer bone touching to that segment. So in case of when you are dealing with the palatine defect, it is this segment which you are dealing rather than anything else. So a fusion of the palate, not only a palate, two secondary palates, but it's a primary palate, and this is what the segment, that's the embryology. And you are, in case of palatal defect, you are evaluating probably this segment. And to what extent you can evaluate, we will think. There was one brilliant paper from Lenhesen that they say they evaluated the abnormal vomer development with an isolated cleft palate. That's what one of the most difficult tasks we are thinking, because cleft lip is easy to see, whether it's the 2D or 3D volume imaging, it's easy to see. You have got the primary palate, you have got a secondary palate here, and you have got a vomer bone. That's a normal anatomy. Now, normally what happens that you have got, if you cut the nose like this, you have got typical vomer bone, but you have got the plate, what is known as the base plate or the foot plate. These foot plates are developed at the base of the palate, and that is what is going to give you a crystal clear idea about the base where it is, the palatal shelf where it is going to attach. In case of vomer, a palatal defect, the vomer is going to be absent, or it may have a U shape, and these U shape, V shape will give you a floating vomer kind of images, and complete absent of vomer is going to be very, 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 very different kind of images. So it's about the vomer foot plate, which does not develop in only isolated cleft palate, and which should be evaluated thoroughly. Now, how we can evaluate? A vomer bone has got a typical base, a wide base kind of the anatomical structure, and that is what we will try to evaluate. In the autopsy specimen, if you really, where you'll have a primary palatal development, a secondary palate, a soft palate, that's how it's going to be developed, but that's the portion of vomer bone is going to be developed, and that is where you will come across. On ultrasound, these are the pathology ultrasound specimen, and this is the ultrasound images. So here I have learned to draw the line on the palate, but a posterior 2/3 you have got the vomer bone. So one of our colleague, Lakshmi Ravi, has described superimposed line sign in isolated cleft lip and palate defect. That's what one of the important point we are going to evaluate that also. Now there are multiple ways how you can do it: MPI, multiple imaging, tomographic ultrasound imaging, render mode, and a magic cut. Adding VCI, that is volume contrast imaging, will give you brilliant some kind of images like that. So what I according to what I'm supposed to do with as per Aris, this is the first step. You are really looking for the fetal mid-sagittal section for your anti-nasal bone and whatnot. Now that is, at that point, just start your volume image. That has to be 25-degree width with only 7.5 seconds. So once you have that volume image, you will have these kind of simple image where you can show to the couple that, okay, look at the fetal face, look at the fingers, and those kind of things. But that's for the patient, not for us. For us, this will rule out cleft lips, but when I want to look at the cleft palate, what I have to do is some special maneuver. I'm going to show those maneuvers here because I'm trying to show it on ultrasound machine with a volume. Look at this.
One of the most important point is this yellow reference. This, can you see the reference dot? So in this, your blue line which is seen.
See, this is one reference dot, and in a multiplanar imaging, this line, if I cut the fetus in this line, what I'm going to get is
in this
that will be seen.
Which is going to be is this.
This is the plane. At the same line, you are going to see the nasal bone. You are going to see the part of the palate, and then then in the third image,
right on the nasal bone. And the moment I cut the face in the red line, like this, what I will see is here.
So these are the point. It's all about the gimmicks of the machine, and you need to zoom it.
And that will help me in zooming the image, and further zooming can be acquired by using this, rotating this knob. So it will give me a crystal clear idea that whatever I am dealing is a nasal bone here. Now, next step, because I want to evaluate the palate, the next important movement is this trackball. If the moment I move my trackball, you can see.
Look at the trackball and look at these lines which are going down. That means I'm cutting this fetus like this sections, and whatever fetus. Look at the changes here.
Just by moving the trackball, you can change where the line is cutting. But then I have put my yellow reference dot right now on the vomer bone, on the superimposed line sign, and where the vomer bone is. Now with the same trackball, I'm trying to move. This is a palate, and the palate. The moment I see the palate, look the palate here. I think I'll explain in my next video.
See that's about the movement. Now look at these are the anatomical specimen. This is a mid-sagittal section. This is a mid-sagittal. I cut the fetus in an axial section. This is going to be the plane, and this is going to be your coronal section dot. Now I'm trying to play this, and here right now this reference dot is on the mid of the palate. Look at the palate. Look at this palate completely. And look at the hard palate which Valdo has shown us. And moving further, I'm going to show that wherever my reference dot at the moment, now I'm out near the lip. I'll show the lip. Now again coming to the anterior part of the palate. Now more and more I'm moving towards the posterior palate. I'm trying to evaluate the same palate like this. And then once I'm here, let me show you at this point. This is the reference dot at the end of the palate. This is the end of the palate at the just posterior aspect of the palate, and you look at the mid-sagittal sign. And once I put on the vomer bone, this is my dot is on the vomer bone. Look at the tip of the vomer bone. That's vomer, not palate itself. And look at this region. Now there are 3 standard planes, but the things are occasionally difficult to make it simultaneous movement. But let us try and understand what actually 2 kind of movements, 2 sectional plane. One is mid-sagittal section and another is going to be the coronal section. Now I'm moving my trackball, moving posteriorly, and here look at this point. At this area, my reference dot is on the top of the vomer bone. So this is the top of the vomer. So you are evaluating the vomer bone here. And once I move my trackball right at the anterior palate, you are evaluating the palate. This is the premaxillary triangle, what you are evaluating. And then if I move it forward, I go back in the midline, I see the full all 3 reference dots there. And once I freeze, now from vomer bone, I have come down to the palate. So this is a mid-sagittal section palate. And from here, if I move it laterally, that is where you will have your, look at this line, you will have a complete 2 lateral shelf of the palate. This is the vomer. So in this region, what you are trying to evaluate is a vomer bone here. That's the vomer bone. This is the foot plate. That is the foot plate. And look at this. These are the 2 lateral palatine shelf. So you are here evaluating the palatine shelf, vomer, and vomeromaxillary junction, and that is what is one of the important sign where you are going to deal with it. Now look at this sign. Again, I am dealing with 2 sections. One is going to be coronal, and one is going to be axial, and one is going to be the mid-sagittal section. Now look at this point. At the moment, my reference point is right now, this is my cut at this point straight. I'm cutting in this line. The palate completely should be seen. These are the complete palate, right? And the left, both palatine shelf coming together. And I'm trying to evaluate. Look at this palate. Look at the vomer bone. Look at the palate. So what you want is a complete vomer is going to be looking different, which is going to fill the gap in the midline. Palatine shelf are going to be in the 2 lateral aspect while you are evaluating at early in the gestation. So that is what you can evaluate a mid-sagittal section where you will come across the palate. superimposed line sign. These are the two important things. Look at the face. That's what you will be evaluating in the mid-sagittal section. In a transverse axial plane, you will be looking at a complete palate like this, and also a uvula, which will be seen like this. And in case of the coronal section, what is going to be the vomer bone, 2 lateral palatine shelf, and that is what you can get it. These are all first trimester evaluation. Now, the same palate, instead of these second trimester evaluation, which is a normal, and your multiplanar plane and this plane of your rendering mode will give you idea about the cleft lip. That's what. Now, let us use the image for us. The same kind of system, what I want is that even in second trimester, you will be able to evaluate 2 lateral palatine shelf as well as the vomer bone, and these things are going to get closed because the palate is intact. The moment palate is not intact, this triangle is going to be wide. It will have wide gap. If it is unilateral absent, you will have only 2 dots. Vomer is going to be wide apart. That is what you need to evaluate. And we have term a PMT. PMT means what we usually try understand is a pre-maxillary triangle. But here PMT is posterior maxillary triangle. So we are coining a new terminology, posterior maxillary triangle, and I'm going to publish a paper on this posterior maxillary triangle in upcoming ESWOG, and the role of the palatal evaluation. Of course, you have got the palate magic cut. You cut the palate, you will see the palate right in the second trimester with an alveolar margins, and this is what this is a normal routine 3D evaluation. But what you can get is of course, look at this simple 3D face, how you can convert into the into the scientific information which you want. Let us try and see this ultrasound clip. Simple 2D face, simple 3D face, rotate. Instead of seeing the face from front, try to look it from below. To see from below, I have to rotate the fetal face in this direction, and then walk through. Here now I'm walking through. This is what I'm going to first see is the mandible, and then looking at a mandible will tell you about the retrognathia and all. Till you cut, you will have a crystal clear idea about the tongue, and then when you still go further down, you will have a very crystal clear idea about the uvula. Here you can see a good uvula, and the same kind of evaluation you can always do with your different kind of skeletal mode. The same, you have to just change your skeletal mode, reduce the thickness, and you will have a complete pre-maxillary triangle with the nasal bone seen. And if you rotate it 90 degree, you will see the bony part of the palate very clear, and also the soft tissue about the soft palate. And so that's what the uvula is. Again, we can have the similar kind of 3-dimensional evaluation with a 3-dot posterior maxillary triangle in a coronal plane, a superimposed line sign in a mid-sagittal plane, and also axial plane at the complete palate. So that's what you can always do it in the second trimester. A uvula, of course, you can have a good option of the uvula once you keep your slice thickness of around 6 millimeter. If you have got 5 to 6 millimeter slice thickness, it not only include the palate, but that also will include the uvula. And the moment you can have uvula, not only like this, you can have a simple like a palate as well as a uvula looking at a bifid uvula. Also, that is what was considered as a mildest form of midline fusion defect. Now, can we really diagnose? What can be seen there? This is a multiplanar imaging. Here again, render imaging, rotating the face as if I want to bring the face in front. These are the 2 eyeballs, pre-maxillary triangle, mandible. So everything, retrognathia ruled out. This is the part of the palate which is seen, and I have just come out in the front trying to look from the below. I have rotated that fetal face. Now walking through from here to here, going up. Look at this. I can see the uvula and this palate. I can see the palate, but look at this uvula. This is a complete bifid uvula, and which you can see a good brilliant uvula, and you will be able to identify a cleft bifid uvula in the second trimester also. Now look at look at the first trimester image, a midline. This is what Ravi has described. A 2D, you can say that one part of the nose is good. You are looking at a unilateral cleft, but what a volume will give you idea. It tells you that, okay, you have got unilateral cleft, you have got unilateral, but nostril is one. Look at the terminated specimen. You've got one nostril, and these are the difficult cases to reconstruct. As my previous colleague has already described, when you have got absent of nostril, and these are the things which you will be able to identify once you are dealing with these kind of palatal defect and these kind of things. But occasionally, these facial profile could be a problem. It may turn out to be normal, just like this. You can see at this point here. Now look at this region. The anomalies can be a gap, cleft lip, palate. Look at the mid-face hypoplasia. Look at the nasal septum deviation, and look at the absence of one nostril. So evaluation of that region, because it's a three-dimensional area. Because it's a three-dimensional area, your evaluation in a 3D will help you. Now look at how this is going to be helpful. This is one again multiplanar imaging. From multiplanar imaging, what I've got my reference dot here is going to give me the clear-cut idea about the defect. Let me go back. Here the dot is, so dot is showing me that there is a cleft lip, there is a gap in the palate, and this is what the gap of the palate I'm going to expect. But it has got also a problem here in that part of the palate on the other side also. Now, what additional information a volume can give you? This is what let us go. I'll zoom it, go and render, take it in the center point. You have got one nostril. Look at the palate, and then you again what simple thing. It's a simple maneuver, and this will tell you about what exactly is going to be the gap and what kind of palate. So this will give you crystal clear idea that you are dealing with what kind of gap and what kind of palate defects. You have got the same autopsy specimen here, and look at the images. On a unilateral side, this is what you can have an advantage of volume. Take which was appearing normal, but look at the rotated image. On the left side, it is going to be right side. This is showing me the defect. So that's what a volume will give you. Again, in a coronal section, look at this. You have got a crystal clear, too wide gap, no vomer bone which is seen, which is quite not there. So you have got a wide gap in the lateral palatine shelf, and it gives you a clear idea that you are dealing with this. Cleft lip and palate isolated. This is simple thing which I think Valdo and everyone has shown you. I'll show you what extra you should do. Apart from this multiplanar imaging, what additional information you should get is a TUI. Tomographic ultrasound imaging and adding chroma will give you at what level these defects are and what is the extent. Because here on the left hand side, you will have a crystal clear marking that you are cutting at almost around 2 millimeter. So I know that if I go from this end to 6, 8, 10, 12, 14, 16, 18, 20, almost 20. This is more than 22 millimeter wide gap is there in the palate. And adding chroma will give you information that palate is missing, and the vomer bone. This is the vomer bone, which is a free floating vomer. And that is what we can really confirm by your volume. Two section side by side. Look at the reference dot here. Just walk through from left to right. I'm moving this line here, and the same amount of the same fetal face you are cutting. Look at the wide gap here. Look at the free floating vomer. In 3-dimensional image, rather than 2, if I go in a 3-dimensional, then MPR, the section in all 3 ABC plane, you have got a free floating vomer here. You can look at a vomer bone, no lateral palatine shelf which is seen at all. So you are dealing with a bilateral cleft palate, bilateral cleft lip, and also there is total absence of vomer, which is going to be quite floating, quite up. So this all a detail, much more detailed information about the vomer and overall outcome. You will have a crystal clear idea about what is going to be the difficulties for the surgeons after the birth. You can always tell them that you are dealing with that much of gap. Vomer is quite high up, so that gap, the structure, the surgical procedure may have their own other implications and your outcome. So that's a free floating vomer. No bones, which are no palate which is seen. You can say pre-maxillary mass is actually alveolar ridge with a very wide base, broad base of the nose, which can be seen. And these kind of beautiful images, they are easy for counseling of the couple. Of course, the recent article which Valdo and I think our first faculty has spoken about 2020 article, the prenatal ultrasound diagnosis of cleft palate without cleft lip. They clearly say that visualization in 3D imaging of a secondary palate offers a new possibility of diagnosis of cleft palate without lip. So a 3D is really important. You need to understand. You need to understand the value, and the moment you will understand the 3D volume, how to capture, how to maneuver, and how to go through looking at both palate and shelf, looking at a vomer, looking at the primary palate, look at the lips, then it is going to make the complete difference. So that's what you need to understand. Some take-home messages: make use of 3D face for us also, not only for the couple, showing them, okay, look at the baby's face, oh, it looks very nice. No, make use for you also. And there you are multiplannar imaging, TUI or MPI addition of volume contrast imaging will help you. Is very useful modality, not only for the diagnosis, but counseling the couple and a possible prognosis. All three sections: axial section, where you can directly visualize the entire shelf of the palate, especially in the first trimester because palate is flat. Now in the second trimester, because palate has got a arch, there again you need the 3D. So direct visualization of palate and a uvula is possible in axial section. Mid-sagittal section, you can look for the superimposed line sign for the palate and the vomer. That's only, but that's the problem with the mid-sagittal section. Superimposed line sign is what? You cannot say that, okay, is right palate is defective or left palate is defective. So when you want to decide the side of the palate, you need to have an axial plane. And that axial plane will have the coronal plane. I mean, that coronal plane where to evaluate a posterior maxillary triangle, what we have right now coined the term PPMT, that assessment will give you more precise information about diagnosis and prognosis. More needs genetic workup with practically all, because 70% may be non-syndromatic. That means 30% are syndromatic. 30% is 1 out of 3. If a nuchal is high, nasal bone is absent, risk is 1 in 3, you are going to investigate that fetus thoroughly. So it's the same situation here. 30% is 1 out of 3. And that's why you need a complete evaluation by RACGH and SOS, next generation sequencing. That's in clinical exome sequencing. Look for the mandible, that is what is, and always store a volume. That storing of a volume of the fetal face with detail will give you crystal clear idea later on if you have missed that some kind of palatal or mandible defect that way. Thank you very much for patient hearing.
Prashant, thank you so much for masterclass in how to obtain those beautiful three-dimensional images and what to look for. So questions here. Obviously, you will do a targeted 3D ultrasound scan when you have a suspicion of an abnormality. But do you use in your practice a 3D image in this way routinely? And if so, what sort of time do you give yourself during an examination?
Because we are evaluating nuchal translucency in all patients, it's the same nuchal translucency image. Just add on a volume. That volume is only for 7.5 seconds. So you are adding only 10 seconds of your evaluation. Anti-image, mid-sagittal, anyhow you are going to get it. Appropriate mid-sag section. So get a volume box, 25 degree, 7.5 seconds or 10 seconds. You will have huge amount of additional scientific information about all angle of the mandible, size, location, right or left palate which are missing. Those shelves are developing, vomer bone is attaching appropriately or not. What is going to be that part of palate? So a lot of information you are going to get it.
Thank you so much, Prashant. Tessa, I see you're still on. Thank you for staying for such a long time. I don't know whether
you told me it was only an hour and a half, Aris.
But you know, there's still so many people online. I know that it's been longer than expected. Tessa, there was a question on when you think about trisomy 13, for example, which is associated with the clefts. The question was, you know, how does this happen? What is the embryological origin, I guess, of this disruption? What happens there? Why is it that chromosomal disorders such as trisomy 13 are associated with this? Is it the tongue issue, or is there a primary defect?
I think there must be a primary defect. I think it's always very difficult to understand the sort of pathology behind a trisomy. When you've got deletions, you sort of can see what's missing. But when you have trisomies, it's much more difficult. And I think a lot of it is that you just have a defect in cell production. I think we have really no idea of why trisomy 13 has this propensity, but why 13 and 18 are such, well, we know that there are a larger amount of genetic material than for, say, trisomy 21, but the actual pathogenesis, I'm afraid I have no idea.
Thank you so much. Well, listen, guys, we've had the most amazing talks today from top experts in the field. I don't know that, you know, there are many more questions and there are plenty of people still online, but I think we've probably exhausted our time limits. Gianluigi, thank you so much for staying on until the end. I don't know if you wanted to have any last words, or Waldo. Otherwise, I will say goodbye and thank all my speakers today, Simon and James as well, who have gone to sleep rightly. I will just remind everyone very quickly, our next online webinar is on the 21st of March. We will be recovering the agenesis of the corpus callosum in English and in Russian. And then please save also the date for the 27th of March, where we will be talking about the problem with cesarean scar pregnancy. Prashant, thank you so much finally for your really brilliant tutorial on 3D. I liked particularly your first slide, which was if you do things if you keep doing things what you're doing, you will get the same result. If you want to get a new result, you need to do something new. So I will certainly be trying something new this week. And,
why I'm saying is because we are all taking this nuchal translucency, everyone. Now we have to just add on 10-second examination. That addition of 10 seconds, because we all are using a very high-end machine, absolutely capable of taking a volume, good volume, just grab it. And then you can, I mean, later on, when you have got time, you can play with one or two, or I consider this my ultrasound machine as my video game. I play with my images. I spend my time after my clinic, if at all possible. I usually don't. I do it straight away, bang on the patient itself. But then, whenever I'm in doubt, I do it that way. So I use as my video game rather than anything else to get some additional information, especially in the fetal heart. When you are dealing with
your passion for the speciality and for imaging shines through, Prashant, and I like that comparison to using it almost as your game and as your entertainment. Gianluigi, Waldo, Tessa, thank you all so much for joining today. And
can I add one comment?
Of course, Gianluigi, always.
It just came to my mind, you know, because we wrote a paper on the prenatal diagnosis of craniofacial anomalies in 1985. So it was the first series that had been published on this subject. There have been a few reports of anomalies, but that was the first series, and we reported that ultrasound could be accurate in diagnosing craniofacial anomalies. And that caused a lot of reaction. The senior author of the paper, that was John Hobbins, received very fierce criticism because that we were accused that we were exaggerating, that we were claiming a level of accuracy that could not be delivered, and that we would raise expectation in the couples, in the patient, that could not be met. And we discussed that over, because the case was very hard. And I remember that in the line of if you keep doing the things that you do, it will never change. Roberto Romero said something that I never forgot. He said, when you invent something, first of all, they tell you it is not true. And after a while, they tell you it is true, but it is not clinically significant. Then 15 years after, they tell you it is true, it is clinically significant, but they all have forgotten you were the first one to tell it. I think that's a very good line.
Thank you, Gianluigi, and a very good place to end. Thank you all so much. And thanks to our delegates. We've had fantastic feedback. And we'll see you soon. Bye-bye.
Thank you. Thank you, Waldo. Thank you, Gianluigi. Thank you. Thank you, Tessa.
Thank you.